Ritesh, kindly unshare your screen, please.
Sir, unshared it.
Okay. Devesh, kindly switch on your cameras. Devesh, may I request you please switch on the cameras? Thank you, Devesh. It is visible now. Yeah.
Trust Academic Committee, Lucknow Heart and Health Care Foundation, Lucknow is organizing 7th Clinical Cardiology and Ecography Update 2020. I shall now request Dr. Sajid Ansari, founder of the trust, secretary of the Lucknow Heart and Health Care Foundation, and founder of SS Heart Care Center, Lucknow, to come and to start inaugural function and facilitate the chief guest and guest of honor. Dr. Sajid Ansari.
Okay, Mike me. Thank you. Welcome our chief guest, Dr. Rajkamal Yadav, our prestigious senior, Dr. Rajiv Asti, Dr. Naveen Garg, Dr. Rajesh Swasta, Dr. Tiwari, and so many my friends. It is my extreme privilege to having this academic activity since last 7 to 8 years. And in this COVID pandemic, meeting was difficult, so this was planned in the hybrid type of conference, like organizing committee people and our senior should be here just for inaugural function, and scientific session will be followed by this function. Before I think I introduce my chief guest and guest of honor, we know that every function should be started with the name of God. So first I will request to our dignitaries that we should proceed for lamp lighting, please. Dr. Rajkamal, Dr. Rajiv Asti, Dr. Naveen Garg, Dr. Rajesh Srivastav, our patron and retired director, Dr. R.J. Singh, Dr. A.K. Tiwari, please. Dr. Kidwai, please come all up. Microphone ready? Hello. Hello. Thank you. We started our function with lamp lighting. Now I would like to introduce my chief guest of the today, Dr. Rajkamal Yadav. Please give a big hand to Dr. Rajkamal. You know, very honestly, when he is somehow known to our secretary, Mr. Jay Prakash, and when I heard that he is from the medical fraternity, so really I glad to invite him. No one can better our chief guest than a doctor who knows doctor better than else. So Dr. Rajkamal Yadav, he started their schooling from Sainik School, Lucknow. After completing, he selected in BVSC, Animal Husbandry and Veterinary Science, in the Chennai Madras Veterinary College. During his study, he gets selected for the fellowship from the USA, Michigan State University, USA. And after that long journey, he selected in proper IS in 2013 batch. Since that, he is serving human being and government organization. Initially, he posted as SDM of the Lucknow. After that, CDO of Pratapgarh, and currently he is director of Ayush Mission, Uttar Pradesh government. I am praying that in future you should become DM of Lucknow. Yeah. So please, I welcome Dr. Rajkamal to please come on the dais. Yeah. Our guest of honor, I will request to Dr. Rajiv Awasthi to introduce boss. I think those who is from the Lucknow, no need to introduction. Yeah, he is very close to my heart and everyone, and he is my, guardian, senior, everyone. He is in the Lucknow. He is the non-physician diabetologist in Lucknow and having a lot of academic activity in the research paper. Please, Dr. Rajiv Awasthi, please. Other guest of honor, our Dr. Naveen Garg, Professor Dr. Naveen Garg, a big stalwart in field of cardiology, intervention cardiology. After completing his DM, he appointed as a faculty in SGPGI Lucknow. And boss के बारे में हम क्या बताएं? He is active in so many forms: CSI, UPCSI, ICC, intervention cardiology, everywhere. And in spite of this, he is a very supporting person and very kind person. Whenever we are calling to him for anything, if we are somewhere need help for the patient or something, really he is helping to all of us, those who is in this field. So welcome to Dr. Naveen Garg. Now I would like to request our patron, Dr. R.J. Singh, please. He is a retired director from the Provincial Medical Service, and because of the Dr. R.J. Singh blessing, we are standing here. He is the patron of our Lucknow Health and Healthcare Foundation. He is alumni of KGMC. I think completed their Golden Jubilee and some other years also. So welcome, sir, to you. Now I would like to request our President of Society, Dr. Rajesh Srivastav from Sultanpur, Director, Ashirwad Hospital, Sultanpur. Please come, boss. He is very known figure. He is in Sultanpur the most time. He looks in the Lucknow because he is very busy in academic activity. And we know his MD, and after that he has fellowship in echocardiography and running their hospital very well, Ashirwad Hospital, Lucknow. So with this, my small introduction, my small words, I would like to start the felicitate our chief guest first. And please, I would like to Dr. Rajiv Ranjan to provide memento to our chief guest, Dr. Rajkamal Yadav. Please. Give a big hand to Dr. Rajiv Ranjan and Dr. Rajkumar Yadav. Yeah. And on the same time, you welcome with a floral bouquet, both. Yeah, please. Floral bouquet one. Yeah. Photo.
सर इस तरफ देख लें सर, उसमें लगा लीजिए।
Floral bouquet दीजिए।
जी इधर देखें।
Yeah. Give shawl also. Yeah. Please. Yes. To provide memento to Dr. Rajiv Asti, I would like to call Dr. Kidwai. Please come. First, welcome with a floral bouquet all together, and then Dr. Rajiv Asti, please. कैसे इधर से आके देना कैसे रहेगा? फोटो कैसे आ रहा? सामने से चढ़। Yeah.
सर ठीक है।
Yes, yes.
आप इधर देखिए।
Yes, shawl, please, shawl. Yeah, give a big hand, please. छोटी गैदरिंग है, ताली बजती रहे। Yeah. Thank you. Yeah. I will request Dr. A.K. Tiwari, please, to facilitate our guest of honor, Professor Dr. Naveen Garg, with floral bouquet. Bring one bouquet, please. Boss, bouquet दीजिए ना. Yeah. Yeah, on same time, welcome Dr. R.G. Singh, sir. Please come, Dr. Salam here. Give me floral bouquet. Yeah. Sir, photo, please. Amir, please, you come and felicitate our President of Society, Dr. Rajiv. Master, please. Yeah. President of the Society and host and everything, senior, everyone you are. Bring floral bouquet, no problem. If memento is you are not able to find out. Okay, thank you. I request all my friends, person and company people, please take their seat and sit with this maintaining social distancing. Yeah, please. Respected seniors, our chief guest, this memory of Mott Charitable Trust is, related to my head. Just I started foundation before 2 years in memory of my mother. And the intention was just to carry out social activity and those who are with me on this group and daily activity, we know we are carrying whatever possible, because trust is not a very rich, because annual turnover is around 3 to 4, 5 lakhs just. So in that amount, we are doing our academic activity. Just now in my parental village, just I would like to share from where Balia I belong, Chitbada Gaon. गर्ल स्कूल में एक प्रांगण में एक चार दीवारी नहीं थी और गेट नहीं था, तो I started it my village to make out in memory of my mother and putting one शिलापट there कि उसमें एक गेट बने और प्रांगण बने. So this was my intention, but on same time, because since last 6 to 7 years I was carrying this academic activity, so I make one academic wing of this trust, and that is Lucknow Heart and Health Care Foundation. And for that, I have our esteemed faculty member from this city, Dr. Rajiv Ranjan, Dr. A.K. Tiwari, Dr. Vijayan, cardiothoracic surgeon, and so many others also. Carrying this activity, without taking much time from my side, I would like to request our first गेस्ट ऑफ ऑनर डॉक्टर राजीव अवस्थी सर कि प्लीज आए और दो शब्द कुछ बताएं।
Thank you, Dr. Sajid, and I wish all the very best to your conference, 7th Clinical Cardiology and Echocardiography Conference. Dr. Sajid, everybody knows, is a very sincere and hardworking person, and he has created this trust, as he has already spoken about, in the memory of his mother. And he has been doing a lot of human work in the past many years, and we have been trying to help him out in whatever way we can. As far as the academic session goes, I have been attending this session for the last 5 years, and it is really, it gives me immense pleasure to see the way it is growing, the way the quality of the conference is growing. Those many people are now being associated with a wonderful program ahead. I wish him all the success. Thank you, Dr. Sajid.
Thank you, sir. Thank you. Thanks a lot for nice words. Now I'll request Professor Dr. Naveen Garg to say a few words for blessing of Allah. Please welcome Dr. Naveen Garg, please.
Good evening. Respected Dr. Rajkamal Yadavji, Secretary Ayush Mission, UP, and the chief guest of today's function, Dr. Rajiv Srivastava, President of the Society, and Dr. Sajid Ansari Sahab, Organizing Secretary of this conference, distinguished faculties sitting on the dais, distinguished national faculties and delegates, ladies and gentlemen. It is my proud privilege to be here as a guest of honor for this inaugural ceremony of the 7th Clinical Cardiology and Echocardiography update. I am really overwhelmed. I am really grateful to the organizing committee and especially to Dr. Sajid Ansari for honoring me. I came to know that this conference is organized every year, and organizing this conference during Corona pandemic is a Herculean task. So my all appreciation to the whole organizing team for this effort. I came to know that this conference is focused on clinical cardiology and echocardiography, and it will be held in virtual platform. To me, the clinical cardiology is the soul of the cardiologist, and the echocardiography is the eye of the clinical cardiologist. So if a clinician can use his soul and use his echocardiographic eyes, then he can be he can make a final diagnosis in more than 90% of the cardiac patients. So this update is very important because updating the knowledge is very essential to update the physician. So I am quite sure that the eminent speakers from all over the India who will be deliberating in this conference will update the knowledge of all of us, which will help us in improving the care and management of the cardiac patient. Now, everybody knows that Corona has snatched away so many things from all of us, but surprisingly, it has given so many things to us. So many things to us. Now the government is focusing, upgrading the health infrastructure with a huge allocation of the funds towards the health infrastructure. And this is going to stay and will improve the health facilities in our country. Now the attitude of the general public at a large towards the personal health has been totally changed. Everybody is focusing on healthy diet, regular exercise, and good night sleep. And all these three things, they are the natural immunity boosters they really boosting the health of our community. And we all know we are using face mask and hand sanitization, and these two simple measures has drastically reduced the respiratory and GI infections. And I will not be surprised if we will continue with these measures, the tuberculosis, disease like tuberculosis will be eradicated in future. And pollution, we all know that pollution has gone down. Rivers have become quite clear, clean, and ozone layer has been healed up. All these things will stay with us and will help the mankind in long run. And another thing which Corona has given us is the Corona has forced us to adopt the telemedicine. And telemedicine is going to stay forever with all of us. And it's a win-win situation for all of us, for physicians as well as patients. Another effect of Corona pandemic is pandemic of webinars. We are having these webinars day in, day out. And previously, only the teaching institutes and selected private institutes were involved. Now you see all the doctors are involved in this teaching activity, and they're discussing out their problems. So it is really improving our knowledge. So this thing is going to continue with us. So, and Corona has also taught us that conference can be held solely on the digital platform or maybe in the hybrid form. And this can significantly cut the budget of the conference and with very little logistic arrangements. So the conference can be arranged very easily in very little budgets. And conference can be done from any place, maybe from the comfort of your house or maybe from the office, and there is no need to travel, and any top speaker from the globe can be involved. Anybody who's sitting in the US can deliver a lecture in Lucknow. So it is now possible. And all these things are going to stay with us even after when the Corona pandemic will be over. So this virtual conference is the best example of this in this direction. And Dr. Ansari has involved the top national speakers on one platform, which I am not possible if he would have done it in the physical form. I think this new normal is going to benefit all of us in the long run. I wish all the success for this conference. Thank you.
Thank you, sir. Thanks a lot. Really, your word will be count for us. And we are practicing healthy practice that related to guideline of Corona. Yes. Now, I would like to request our chief guest, Dr. Raj Kamal Yadav, please come and few words, please. Welcome to Dr. Raj Kamal. Give a big hand to him, please.
Thank you so much, Dr. Saab. At the outset, let me first congratulate each and everyone who is associated with this conference that in these difficult times you have organized and successfully hold the program for such an important topic for humankind. You know, Indian society, जब से आप लोग देखे होंगे, मतलब हम लोग तो बचपन में यही सुना है कि यूजुअली जो लोग पहचानते थे पहले वो केवल या तो डॉक्टर या बैरिस्टर, दो ही लोगों को जानते थे, और बाद में आके जब देश आजाद हुआ तो कलेक्टर. तो आई थिंक के ह्यूमन हिस्ट्री में, ह्यूमन काइंड में, द काइंड ऑफ place which a doctor plays, the kind of dignity, the kind of respect, the kind of service which is expected out of him, that is immense and very, you know, hardworking. It takes a toll on everything. It takes a toll on your personal life. It takes a toll on your professional life. It takes a toll on your whatever is involved with you. It takes a toll on that. So I have a huge respect for all of you, and I seriously, pray God that all your endeavors come true. And as our previous speakers has said, both of them are with us, and Dr. Garg and Dr. Awasthi ji, both of them are very eminent in their fields, and everyone who is present here. And this is a topic which is, it's with the increasing, discrepancies in our lifestyle and, heavy work hours, whether it is administrative work or any professional works, the kind of heart problems and the kind of lifestyle diseases are coming up. I think these are the means which can enable and enhance, the knowledge sharing basis, and because of which one can gain, as sir has rightly said, that now the boundaries are no barriers. One can learn from a very good practitioner, from a very good academician who is sitting right across US, and share his knowledge with the people who are working in Lucknow. So I think this kind of organizations, this kind of ventures, and this kind of events help us to do that. And more than that, what really made me come here and to come here and to speak in front of you was the effort that, other than your doctoral work, you're also doing a wonderful job in coming out as a community service by means of your trust. So that is a very good initiative, and I really wish that if we can be of any help in that in near future, do let us know. And with these words, I'll really like to wish you a very grand success, that may this event hold very high regard in every clinical person who is practicing anywhere in country and is attending with us, and many more such conferences to come in the future. Thank you so much.
Thank you, sir. Thanks a lot for nice words. Really, that count for us. Sir, from last 3 to 4 years in every conference, I am releasing one cardiology update. Yeah, that is, I mean, a smaller one, but not, and which me and Dr. Rajiv, Dr. Tiwari is here. So giving their contribution, Senior Dr. Rajiv Ranjan is here. So I would like to inaugurate this update by our chief guest and guest of honor, please. That is clinical cardiology, please, boss. Yeah. We have article from all the friends, Dr. Tiwari, Dr. Srivastava, Dr. Salam. Yeah. Thank you. Thank you. Thank you. We have very small topics in this and that related to day-to-day clinical practice. For this, organizing this activity, these events, I would like to thank for all the friends, senior, those sitting here in our organizing committee, our secretary, Mr. Jayaprakash, Dr. Kamlesh, Dr. Kidwai, Dr. Amir, and our special thanks to our engineer Piyush Shankar, who supported me for a lot of this, doing our technical work, and all the friends who give me time and support us. And at last, I would like to invite Dr. Rajiv Srivastava, please, to come and give vote of thanks. Welcome to Dr. Rajiv Srivastava.
Thank you, Dr. Sajid Ansari. Before starting this last ceremony, I would like to say something about Dr. Sajid Ansari. Dr. Sajid Ansari is very close to my heart, and we met at Delhi when we were taking a training for fellowship in echocardiography. I found him very noble person, and his quest for knowledge is tremendous. People after getting into practice don't bother about the recent advances and quest for knowledge. People are only busy with making money and doing business. But I have seen that Dr. Sajid Ansari being a very noble person. And I have seen that he has got as a non-invasive cardiology. He is a non-invasive cardiologist, but he has got facility for treadmill tests, echo, doing Holter monitoring, PFT and whatnot. So, gentlemen, there are two types of cardiologists. One cardiologist, they are cardiac physician, they are the real cardiologists who are super specialists. And the other cardiologist is a physician working as cardiologist. So me and Dr. Sajid, we are physicians, we are not true cardiologists, but we have a focus on cardiology. And such cardiac physicians, such physicians who are working mainly on cardiology, whose practice involves more than 60 to 70% of cases of cardiology, they form a very good link between the cardiac physician and the common masses. We know that in our country, most of the rheumatic heart diseases, most of the diabetics, most of the persons having ischemic heart disease, they are poor people. They cannot afford to reach the tertiary level. A poor laborer who is having a heart attack, how can he venture to go to SGPGI? Never. So we, the physicians who are working in C class and B class cities, there is no scope for super specialists in those cities. So we are a link between the super specialist and the common person. So this is that gives a very good platform to the super specialist also. So we are examining the cases, we are working out the cases, and we are avoiding unnecessary. Those patients who are functional, those who are having not serious heart disease, they are running to SGPGI, but we are cutting down that burden to the super specialist. So Dr. Sajid Ansari is a real cardio physician. He is a physician, he is MD medicine, but his main focus is on cardiology. He did his fellowship in echocardiography. He did his fellowship in Indian Society of Cardiology. So I think such cardiologists, they are very much required in our developing nations, where there is a lot of paucity of super specialists. So such cardiac physicians are very much required for developing nations who are a link between the poor mass and the super specialists. So I must pay my thanks for giving this honor to me. And from the core of my heart, I will thank Dr. R.K. Yadav, who has spared his valuable time from his busy schedule and has made this, has given grace to this occasion. And I'm very thankful to him. I'm really thankful to Professor Naveen Garg, who is a real cardiologist and real human being. I can tell you that on a phone call, he is always ready even at the dead of the night to help any patient. He is such a noble cardiologist. I'm thankful to Dr. Rajiv Awasthi, who is a very reputed physician of the city. At the same time, thankful to Dr. Ajay Singh, who is, I think, is the most senior person of the medical fraternity in Lucknow. So we have all the honor for him. And I will thank to all the pharma persons, all the participants. I'm thankful to Dr. Rajiv Ranjan, Dr. Tiwari, and Dr. Vijayan sir for participating in the conference, in the feast, that CME. We will be having a very nice academic feast just after this. So I must thank all of you from the core of heart for making this a successful event. Thank you so much.
Thank you, boss. Thank you. Really wonderful. In this gathering, I have few of our special guests, seniors and distinguished person. So please welcome Dr. Muklesh Gupta with floral bouquet and provide memento here, faculty memento here also, please. I would like to call Dr. Salam, please come. Boss.
Thank you.
Boss is secretary of our LDS society and always supporting. And very good academic person. Seeing us a lot. Thank you. Welcome to Dr. Raju Ranjan. I would like to call Dr. Kamlesh Yadav, please. तालियां बजती रहे भाई। कहाँ सो रहे हैं आप लोग? On the same time, I would like to welcome Dr. A.K. Tiwari sir. Please come and give bouquet and memento to Mr. Kamlesh. Please you come and आप ही deliver करिए. Yeah, you come and deliver. I would like to welcome our Joint Secretary, Dr. Vijayan, my junior from Lalamite and Dynamic Cardiothoracic Surgeon. He is Joint Secretary of Lucknow Heart and Healthcare Foundation. Please come here. Welcome, Kamlesh. Yeah. You. Piyush, you also come, please. Yeah, you also come. Join that. Yeah. Give moment. Just wait 1 minute. Yeah. Thank you. And I have few members of our organizing committee, just 1 or 2 minutes, I would like to recognize their effort here. So providing memento to him, Dr. Kidwai, please come. Dr. Kidwai, and give memento Dr. Kidwai by Wasim Ansari. Yes. Mr. Jay Prakash. Yeah, a guardian of when I came in Lucknow 2008, he is the really person who started supporting me and not professionally, but teaching the humankind how to survive in Lucknow. Please, yeah. Dr. Salam, please come. You collect your moment. Piyush Shankar, please come. थोड़ा इधर आ जाइए, फोटो में सब लोग आते रहे, हमारे डिस्टिंग्विश गेस्ट आते रहे भाई. Yes, Dr. Amir. Yes, and at last, that is from my family member. My elder brother is here, luckily, Mr. Sabir Ahmed. हमसे बड़े वाले भाई आए हुए हैं, मैंने उनको बुलाया कि आप हमारे साथ चलें हमारे फंक्शन में. So please give one memento and welcome you to floral bouquet. Thank you. Thanks a lot. If someone is, I forget it. Yeah, no problem. We will be here. We will organize again. Yeah, Dr. Kamlesh. अब भाई आओ यार. तुम डबल मास्क लगा के बोल रहे हो. तुम एडिशनल सीएमओ क्या होगे? बिल्कुल गाइडलाइन में हो. एक लगाओ. At last, I will like, yes, we remain. Dr. Kidwai, please come. आप देने में रह गए, लिए नहीं, मोमेंटो लिए नहीं आप. Okay, please. Okay, with this small presentation and function, I would like to thank everyone, my guests, my senior those sitting here, our organizing committee people, and at the same time, pharma people, those who supported for this academic events, and even they supported for their speaker also, arranging a speaker from this distinct places. And thanks to all. And now welcome for just having a snacks and tea break. Please.
Hello. Hello. Hello.
Yes, sir.
Am I audible?
Yes, sir, you're audible.
And I'm visible also?
Not yet. One second, sir.
Yes, sir, you're
Yes,
visible
sir,
also.
you're visible.
Okay. It's fine.
कर दिया मैंने
Start कर दो।
Good evening, Dr. Rajiv.
Good evening, Dr. Sanjay Tandon. Welcome for the
Thank you.
academic feast.
Thank you.
And for the first topic, you will be as chairperson with Dr. Sudeep Kumar, who
Yeah.
is Associate Professor of Cardiology in Department of SGPGI. He has got very much interest in academic sessions. He is a very good interventional cardiologist, and as a person, he is a very humble and very good cardiologist.
I think he is finding it difficult to join in. So Deep has sent in a message.
Okay, okay,
Tell people to make him join.
okay.
Maybe-
Dr. Sudeep could not join. Sudeep
Sure,
Kumar.
sir. We'll take care of that. I'll just discuss with the Sudeep, sir.
Sure, sure. We are
Yeah.
waiting for Sudeep to join, please.
Yeah, sir. I'll make sure sir will join. Yeah. I'll just follow with sir.
Okay, then we are waiting before starting.
Yeah,
Yes.
yeah.
Dr. Sudeep could not join.
समीर सर सुदीप सर का मैसेज आया प्लीज लेट मी इन करके
Yeah, sir has joined. Raju sir, you're on mute. Sir has joined.
No, he's not there. Sudeep.
Sir, good evening.
Sudeep, hi, good evening.
Good evening, Dr. Sudeep. Welcome to the.
Arey, sir, Raju sir, very good
okay.
evening. What a new hairstyle.
Sir. It is all COVID.
COVID hairstyle. Good.
Effect. It is all COVID effect.
COVID effect.
All doctors are very afraid of going to their barbers.
Sir,
Most of
देखिए, home haircut.
people having home
Same here,
cutting.
same here. Same here.
Most of the people are having home cutting,
Ek-
domestic cutting.
Clipper.
You ask Nilima to do that.
She has once done, but she is preparing for the second cut.
Second one. Okay. Okay. That's great.
So
Also,
we will start after 2 minutes. Okay, sir.
okay.
I think Dr. Rakesh Gupta is a speaker. He has to join from Delhi.
Okay.
Sir has joined, sir. Sir has also joined.
Acha, he has joined.
Yes, sir.
Rajiv, I'm sitting there, man. I'm listening.
Thank you, sir.
Talks.
Yeah, yeah. Good evening,
Thanks a lot.
Dr. Gupta.
It's a great pleasure to see you on internet once more, sir. It is always a great feast for us, sir. As a teacher and as a friend, we are always obliged.
Thank you, Rajiv. Thanks a lot.
So we will start in 2 minutes, sir.
Okay. No problem.
I know.
Are you live already?
I-
For the audience?
Yes, sir. Yes, sir. We are live.
Okay. You're
We are live already.
okay.
Take your own time. I'm there already.
Good evening, viewers. I welcome you all for the present academic feast. Today we have galaxy of intellectuals from the field of cardiology. And the first and foremost speaker is Dr. Rakesh Gupta, who is a cardiac physician as well as a master of echocardiography. Dr. Rakesh Gupta is working as a professor and consultant in Max Hospital. He is having his own Echo Drop Institute. He is holding the post of director in Drop Institute. He has been the past president of Echocardiographic Society, Indian Academy of Echocardiography. He has been the past president of Cardiological Society of India. He is imparting training sessions to so many cardiac physicians. He is holding the course of recent advances. He is holding the course of fellowship in echocardiography. I think he is the first person to start fellowship in echocardiography in India, which is recognized by Annamalai University. So he is a very great researcher in echocardiography. So after introducing Dr. Rakesh Gupta, the chairpersons in the session will be Dr. Sanjay Tandon, who is a very eminent physician in the city of Lucknow. He is still a president of API chapter Lucknow, and he is a very eminent physician in Lucknow. The other chairperson will be Dr. Sudeep Kumar, who is holding the post of professor in cardiology. He is a very great researcher. He is special interest in interventions, and to his credit, he has got so many publications in several Indian and foreign journals. So after introducing the chairperson, I will request Dr. Rakesh Gupta to start the topic. The topic is systolic heart failure echocardiographic evaluation, its clinical application. So I would request Dr. Rakesh Gupta to please start the topic. Thank you, sir.
Thank you, Rajiv. It's a pleasure to be on this platform. Let me start with this presentation of 57-year-old male who had a chest pain of an on, not definitely characteristic of a coronary artery disease, but findings. Clinically, it was normal. And let's look at an echo first picture. That's what we do in a plaques window. That's everybody says is anterior septum in the posterior wall appears normal. And here is a two-chamber view, the anterior segment model. Three-chamber view, again talking of anterior septum and the posterior wall. The most important thing is, if you look at this picture together, we hardly find any wall thickening abnormalities. And many of our colleagues which are doing echocardiography, they look at this kind of a picture and they say echo is normal. Let me move on what exactly we have in this patient. If we talk of ejection fraction, the most common method employed by anybody today is a visual ejection fraction. Very little time, not based on a guidelines, and on top of that, it requires a lot of experience to talk of ejection fraction. We talked about wall motion abnormality. Does this patient had any wall motion abnormalities? Many people will say none. But let me share you a couple of images from a myocardial contrast echo. Here is a picture. Here's another picture from myocardial contrast echo. And look at this myocardial contrast echo. Subsequently, we say that possibly she does not or he does not have any significant wall motion abnormality. Along with the wall motion abnormalities, and you can see over here, the mid and basal septum appears to be hypokinetic if we started looking at the 3 dimensions myocardial contrast echo, and 3-dimension 3-chamber view, and along with 4-chamber view. Moreover, thus we went on to do a tissue Doppler imaging, a quantitative estimation. Look at the septal velocity, which is only 4, lateral is 3, anterior is 4, inferior is 5, and the posterior is also reduced. To us to say that this patient has got significantly subclinical LV dysfunctions. Is not only that, we looked at RV free wall TDI, even that was low, like 8 centimeter, with the cutoff is 9. The 2-dimension stain, which is again a quantitative estimation better than a tissue Doppler imaging, shows something different in this patient. And what was different in this patient was we had a reduced stain in a different kind of a territory. Mean to say that, look, echo is not what we look at in 2020. We have many modalities to talk about 2-dimensions echo along with 2-dimension stains. If you have to look at all these things together, let's see what is there in armamentarium to talk about real echocardiography is. Let me change my circuit to talk about a systolic function. I hope the slides are seen by everybody. We are going to talk about importance of a method of evaluation. 21. Can systolic function by echo gives us a similar information as MRI, and can we assess a subclinical LV dysfunction? That is what the need of a day-to-day is. If you look at this pyramid or the staircase of evaluation, the most common method which the people evaluate or use is the visual ejection fraction. Very little time consuming, reliability may be questionable, requires a vast experience and overused in clinical practice. But if you talk of a 2 dimensions biplane ejection fraction is the most dependent, quantitative method, requires experience and a guidelines base. And if you talk of 2021, I'll say 3 dimensions, fully automatic, fastest method with increased precision, closest to MRI is the answer. Well, when we talk of a systolic function, we talk of a CAD, important prognostic marker in CAD, CHF, and a cardiomyopathy. It is being influenced by many, many factors. And I always say it is influenced by everybody as a newly bride which comes home, being influenced by father-in-law, mother-in-law, husband, and everybody at home. So is the ejection fraction, which is being affected by after, pre, and contractility along with the heart rate. And many factors that depend on this preload and afterload. And I always say, look at a systolic blood pressure of these people when you look at the ejection fraction, because afterload makes a lot of difference in evaluating ejection fraction. What we need to look at in LV function is, we look at a global, we look at a regional, and then contractile ejection fraction. And many modalities, as I showed you in a couple of minutes back, talking of all these things. Let me take one by one together. M-mode ejection fraction by Tricole's method. Many people have been using it even today. Now the method was invented almost 40 years down the line, and everybody appreciating if my apex is bad, what will happen to bases? They'll be hypercontractile, leading to very high, overestimated, false, normal ejection fraction when the global ejection fraction is fairly low. And that's what we say note in 2020. Then MAPSE is one of those things which were used earlier. We still use them today when we are down with many times of poor imaging quality to estimate a rough ejection fraction. And this has been given good correlation in 2013, talking of MAPSE in shock, the valuable echocardiographic parameter in intensive care unit. Believe my word, we still use this modality when we are in ICU or a CCU, when we do not have a good imaging quality. And when we use this imaging quality, we can calculate the formula is being published in JACE 2012, talking of a MAPSE, and you can calculate ejection fraction utilizing this formula. And when we use this MAPSE along with mitral annulus tissue Doppler S-wave velocity, we had a significant better correlation to look what is normal ejection fraction, what is abnormal ejection fraction. Real-time two-dimension ejection fraction, this is what is their most commonly used modality in 2020 is, it gives us a volume and ejection fraction, cardiac output, stroke work, and LV chamber dimensions and thickness. As I said, the most important quantitative, semi-quantitative method is eyeballing, whereas the quantitative method in 2020 and 21 would be the biplane, accurate, and guidelines based. This is what the image everybody says, eyeballing. But I say it's large experience is required to talk of ejection fraction. And even after practicing 40 years of echocardiography, I can tell you still, I make a lot of mistakes when I'm pushing my heart patients when we are overloaded with echocardiography to look for eyeball ejection fractions. This is the 16 segment model, which we analyze based on a coronary artery supply, leading them to normal hypokinesis, akinesis, or dyskinesis to talk about the various things in a wall motion abnormality. Then come regional analysis. The base of this regional analysis is obviously the hypo, A, and dyskinesis. Then the next question comes, which is the best method of ejection fraction as on today in 20? I say the biplane Simpson's method is the most important method of calculating ejection fraction in 2021. And the most important thing is this biplane method has an additional modality which can really make your images good by utilizing harmonic and myocardial contrast echo. And this harmonic imaging, you can look at how good the endocardial border delineation is when we have a harmonic imaging, whether it was a short long axis or a short axis to talk about this, and leading to a ejection fraction of 52 versus 54, we have a certain reduced ejection fraction of less than 40, 40 to 50, 49. That is so-called a mid-range ejection fraction or a normal ejection fraction of more than 50%. What many societies, they apply on this. What is the utility of these ejection fractions? When we calculate by 2 dimensions, biplane ejection fraction is, look, here is a chart based on which we recommend which kind of a therapy should be advocated. But at this point, I like to say this chart belongs to 2017, where sacubitril and ARNI was not recommended. But about a month back, when the paper was published, where ARNI was found to be still useful in cases of a heart failure preserved ejection fraction. Why we look at ejection fraction? Here's the real answer that gives a lot of therapeutic value for ejection fractions. Myocardial contrast echo, easily available. We do a lot in our lab, and it's a small micro bubble which really helps in looking a very good black and white interface, or what we say salt and paper interface. We can really get a good imaging qualities, and we can really calculate a good generation fraction where the images are suboptimal in this particular fashion. Let's move further. It's not only the ejection fraction which make a lot of difference. We have to look at the various other things which are possible as on today. What is there in 3 dimensions echocardiography? This is a picture of 3 dimensions echocardiography, triplane method, which gives you an online end diastolic, end systolic, ejection fraction, stroke volume, cardiac output, and a heart rate in one go. And the most important part of this triplane ejection fraction is it gives you a global ejection fraction where the 2 dimensions give you only a 2 dimensions ejection fraction, which is being available with GE today and being patented by Philips, gives you an online 3 dimensions, a true ejection fraction, which correlates very well with cardiac MRI. The best answer is with this method, we get a very good answer for the mass or LV mass, which we look for various things in our studies. Next comes, we not only look for 3 dimensions, 2 dimensions, or M mode ejection fraction, we look really for a quantitative ejection fraction. That is the insight today. And one of this quantitative ejection fraction is a very simple thing, which we have been doing over a period of time, was to look at a cardiac output by looking at a LVOT diameter and along with the LVOT VTI. And the second thing, which was used as a myocardial performance index, to give you a good amount of information whether this patient has got a poor LV systolic function or the improved ejection fraction. I always say this particular phenomena when I teach to my student is, look at a dilated cardiomyopathy. What do we get in this dilated cardiomyopathy ejection fractions? Look, I'm not really sure if I do my ejection fraction in the same patient who comes performance index. And if their myocardial performance index has become better than before, obviously we talk of like the patient has become better. Second thing is, look at LVOT VTI. If the heart rate and a blood pressure is the same, if the LVOT VTI, which was 20 earlier, has become 24, it means my LV function has become better in this particular patient of dilated cardiomyopathy. Next thing comes tissue Doppler imaging, 2-dimension and 3-dimension stain. Here is a tissue Doppler wave. We don't going to focus on a diastolic wave. We are going to focus on a systolic wave. And that's what we're looking at the septal annulus. We get a septal systolic wave. Looking at the lateral annulus, we get a lateral systolic wave. Anterior, inferior, and posterior. All of the annuli can give us a very good answer for a systolic TDI velocity in systolic function. Can we have any outcome of this? Look, this has been given a very good modality of utilizing this TDI velocities. Published in JACE in 2014, talking of all these kind of a thing, especially in people who are on a chemotherapy, like anthracycline-based chemotherapy, or we talk of a 2-dimension stain. When we use this 2-dimension stain and that we look at the patient on a breast chemotherapy on a trastuzumab, where we use, if the fall of more than 15% of a 2D stain has happened after trastuzumab therapy, obviously we look at the stain value and when to postpone or hold on the therapy for certain time. Similarly, can we say that patient who is presenting with a dilated cardiomyopathy is ischemic versus non-ischemic? Here the 2-dimension stain can give us a very good value, whether this map is a uniformly normal map or a variable map which differentiates you whether this is an ischemic cardiomyopathy versus a dilated cardiomyopathy. And if you look at a contractile reserve, obviously dobutamine stress echocardiography can give you a very good answer whether the person has got a normal response, stunned myocardium, hypernetic, ischemic, or a scarred myocardium, because based on this, we look at a revascularization, because if a person has got a good revascularization viability, he is ideal candidate for revascularization, versus a person who does not have a viability should not be subjected for revascularizations. Many more things we do with this kind of a ejection fraction. We look at a less than 30%, 35% of ejection fraction to look at the candidate who are for ICD implantation in sudden cardiac deaths. Now coming down to the most important thing in next 5 minutes, talking about the clinical impact in practice. Lately, I'm not talking of something in 2019 or 2008 triple vessel disease. Ejection fraction calculation by 2-dimension stain, identification subclinical LV dysfunction, identifying the etiological pathogenesis of LVH. This is what paper which we did in our lab when we subjected our patients of a triple vessel disease before doing angioplasty because the patient refused for a CABG. We did a 2-dimensional stain before and 2-dimensional stain afterwards. And after 2-dimensional stain after stress, whichever the territory showed the reduced amount of a stain, the maximum reduced amount of stain, we picked up that particular vessel and subjected to angioplasty. And till date, we have done 26 patients in last 2 years and came out to be a very good results. Next comes calculate of ejection fractions. What by 3, it gives you a very good amount of ejection fractions. Next comes the value of utilizing a subclinical LV dysfunction. It's not going to be if less than 50% ejection fraction versus 59, which is a change parameter as on today. But if the ejection fraction remains the same, but they may have a significantly reduced GLS. Here's an example of 67% ejection fraction versus 64% ejection fraction, but GLS was entirely different. And this candidate who had a reduced LV systolic function, now subclinical to undertake for a patient for aortic stenosis for intervention. Similarly, looking at this GLS, a longitudinal stain in asymptomatic patient with severe chronic aortic regurg with preserved ejection fraction. Today, the data says if the GLS is low, and if the GLS is low, these people should be subjected to earlier surgery to have a better cumulative outcome of these subjects of populations. Next comes the case of a COVID cases. Now, what we have done in last 8 months of our practice was one of this case of a 40-year-old male, marked weakness for 1 month, breathlessness or exertion, non-specific ST wave changes, chest mild cardiomegaly. And you look at this echo. If you look at this echo, although the frame's not playing as such, but they had almost normal LV systolic function. When we looked at a 2-dimensional stain, it was markedly low. And when we looked at this 2-dimensional stain, these were the people who were suffering from myopericarditis with almost normal ejection fraction, and GLS was significantly low in this subset of population. And subsequently, this kind of a paper was published in American Journal of Cardiology talking about prognostic value of LV global longitudinal stain in COVID-19. And they categorically said at the time of admission, if the GLS was significantly low, they had a cumulative survival was significantly poor. Similarly, the RV stain, which was evaluated in COVID-19 patients, and if they had a poor, obviously they had a poor outcome. Last to come out, I'll say, learn with this article of accuracy of LV cavity volumes and ejection fraction for conventional estimation method and 3D surface fitting. What does this says that? It says that most important thing is, it says that large error of LV volume and ejection fraction estimates are present when relying on 3 or fewer measurements and simple geometric method like Tichols, that we should give it up completely. LV volume ejection fraction error are expected to increase substantially for imaging modalities and slice participation prescription where endocardial border is less accurately delineated. And that's what exactly happens. When we can't see an endocardial border, we cannot estimate a correct ejection fraction. And the most important thing, what they say is combining geometric info model of LV ventricular endocardial surface enables the quantification of small, less than 5% changes in left ventricular volume and ejection fraction with statistically significant certainty, thereby reducing the number of subjects needed for clinical trial and permitting earlier diagnosis of subclinical cardiac dysfunction. Mean to say that give up Tichols completely. Spend time for 2 dimensions biplane the best to give you a good ejection fraction. In summary, I can say that the keyword is 2 dimensions echo. Precise calculation, use the help of ability if you have a poor images. Doppler echo, myocardial performance index, especially in poor LV systolic function or a patients where you can't look at the images properly. 2-dimension stain and spectral imaging. This is the real thing right now. And we have shown many examples identifying synchronicity, identifying the culprit vessel and triple vessel disease for non-surgical interventions. And that gives you a lot of value for systolic function. And if I have to conclude further, I say 2 dimensions biplane method, modified Simpsons is the answer. If you have a machine, 3 dimensions automatic. Quantitative ejection fraction is a true answer, and cardiac MRI, it correlates very well with 3 dimensions automatic ejection fraction. Last 1 minute, I say use initially. Look at this picture. This picture looks gorgeous, and I'm sure everybody says this picture is gorgeous. But if you do not ejection fraction properly, look at this picture in a final session. What the true picture is, it gives you a certain time to give an exact true picture over a period of time. And that's what the ejection fraction is. Here comes the true ejection fraction. Thank you very much for your patience here.
Thank you, Dr. Gupta, for that excellent deliberation on evaluation of systolic functions with echocardiography. You've given us the various modalities by which you can estimate the ejection fraction in different conditions. I'll request my co-chair, Professor Sudeep, to go ahead and if he has any questions or clarifications to make.
Thank
Professor
you.
Sudeep.
Thanks, Dr. Gupta. Very illustrative presentation. I heard kinesis after a very long time. Use of the word color kinesis. Nobody is in the newer generation. Nobody heard about it. What is the color kinesis? But we used to do it. The color kinesis. Dr. Gupta, but on all the latest machine have inbuilt harmonic imaging. We don't have to switch on or off the inbuilt harmonic imaging. And one more, so what do you say about the loading conditions to overcome over the loading condition? For example, you very well mentioned that it should be measured in the context of the blood pressure after load, etc. So how to overcome that loading condition and the lacuna of the ejection fraction? There is lots of echo.
So ricocheting.
I'll try to rectify that, sir. Yeah, please carry on.
Like you have to switch off everybody's, make them mute or switch off their images also. Like
Sure,
the most important thing is loading a can I say now?
Yeah, please go ahead.
Look, the most important thing is when we look at these LV functions they are being determined by preload, afterload, heart rate, and many things. And these things are very common when the patient is hypertensive, tachycardic, like in congestive cardiac failure. We look at an ejection fractions and we make an estimate, look, this is the ejection fraction is. But if you really want to look at ejection fraction, let these people settle down over a period of time. That's what we do in our lab is if the patient is tachycardic or hypertensive, we ask them to come back again for reevaluation of their ejection fraction. If they're in congestive cardiac failure, all of us understand if the patient is preload or afterload, which is loaded or things are there, we always tell them to reevaluate the ejection fractions. And we have seen these kind of a thing very commonly in ICU setup when we have ejection failure, when the patient has settled down with tachycardia, the ejection fraction either improves or deteriorates, whatever the answer is. So my humble suggestion for people, doing a good echo is always look at these pictures, always look at these images once the patient has settled down clinically to give them a value. And I always say one more thing, like when we do these kind of an echo in our labs, especially in a tertiary care hospital, when the patient comes out with 25% ejection fraction, my interventional colleague want to jump onto IC. Let's make this patient settle down. And once the patient settle down, then we talk about these ejection fractions and give you an exact value whether this person needs an intervention or does not need an intervention.
So, coming on to that, your nice suggestion that we should settle the patient first and look at their parameters about the heart rate and the blood pressure, and then interpret the ejection fraction in context of the clinical condition as well as the hemodynamics. So, so what is your view on that?
Correct.
That the use of means pre-ejection indices. So do we have any role right now, or now we are jumping into the GLS only? Am I audible or not?
You are audible, but I
We are
don't
jumping
think
to more time like GLS now.
Yeah. So one more small query. So what is the utility of the pressure volume loops generated by the echocardiography? There is a very good article of Shantanu Hussain. So I'm really curious about the
Yeah,
work.
it has come up very well. Like if I can, you can hear my voice. The
Yeah,
pressure
I
loop
can.
particle will play a significant role over a period of time. Many machines have come up with this kind of a things now. It will have both impact. It will have lot of impact in a time to come, especially practical in our setups now.
Well, Dr. Gupta, for the benefit of the physician forum that is mainly listening to the talk, I'd like to ask you where exactly is the role of tissue Doppler while we are requesting for a echo? So is the pulse wave Doppler that is normally being done is okay, and what specific indication should we write tissue Doppler? How is it going to benefit as far as echo is concerned? Am I clear to you, Dr. Gupta?
As far as physicians are concerned, yeah, it's clear to patients are diabetic patients in high conditions, in patient on cancer chemotherapies. There we should use it. I did not use those slides for a tissue Doppler in diastolic functions. If you look at a tissue Doppler, you can identify subclinical LV dysfunction in diabetes hypertension subjects.
Okay. That will be a better modality in the case of diabetes and hypertension if you want to look in for early dysfunctions. Thank you so much for that excellent talk. I think, Sudeep, we are overshooting the time. You can conclude the session and over to the organizers.
I think with in the paucity of the time, we should come to the but there's lots and lots to be discussed on the ejection fraction, especially the systolic ejection fraction, especially when we have such a stalwart on echocardiography who can clarify our doubts, our etc. So let me conclude the discussion so far that ejection fraction should be taken into the context of hemodynamics, and it is a very load dependent, and also we should be taking newer modalities of the strain, especially the 2D strain, the GLS, etc. And as Dr. Tandon has pointed out that its utility lies into the subclinical LV dysfunction and the follow up the LV dysfunction. When the subtle change in the LV function is very important, for example, the chemotherapy, and Dr. Gupta has already pointed on that. So regarding the utility of the tissue adapter, I think the next talk is on the diastolic function by Dr. Rupali Khanna, who is my colleague and very good in the echocardiography. So we'll continue to hear that, and let's have conclusion to this talk. Thank you very much.
Thank you. Thank you, Dr. Rajiv.
Thank you, chairpersons, for this thought-provoking talk. In fact, ejection fraction is the heart of the echocardiography, and we have to be very careful while we are measuring ejection fraction. Now, second topic of the day is diastolic heart failure, how to diagnose. The topic will be delivered by Dr. Rupali Khanna, and the chairpersons are Dr. Rajat Jain and Dr. Rishi Sethi. Dr. Rajat Jain is a professor of medicine in MLB Medical College, Jhansi. He is a very good diabetologist, having a very good practice, and he is a very prominent physician. So, Dr. Rishi Sethi will somehow not join today. I would request Dr. Rajat Jain to introduce the speaker and proceed with the talk. Dr. Rajat Jain, please.
Thank you, sir. Thank you. The speaker of this session is Dr. Rupali Khanna. She is additional professor in Department of Cardiology, SGPI. She is a specialist in coronary imaging, intravascular ultrasound, and optical coherence tomography. She is doing advanced echocardiography and also gives training in echocardiography. I have attended one session of echo course from her. She has done so many TAVI, that is transcatheter aortic valve implantation. She has so many, more than 50 research papers published in various journals, in national and international journals. And at present, she is a shining star in the sky of cardiology department of SGPGI. Without wasting much time, I invite Dr. Rupali Khanna to deliver her lecture on diastolic heart failure.
Before Dr. Rupali Khanna may start, the panelists of the topic are Dr. Sanjay Arora, Dr. Muklesh Gupta, Dr. Shahbaz Ahmed, and Dr. A.K. Srivastava. Now, Dr. Rupali Khanna, kindly start your topic. Thank you.
Thank you, sir. Thank you, Dr. Rajat, for such a vivid description. So, after assessing after listening to all the systolic dysfunction, and my topic is basically limited to diastolic dysfunction. Now, these patients coming with diastolic dysfunction, how to assess them. So it will be a very basic topic. I will start with a case example. The patient comes to your OPD, how you approach this patient, and what are the different tests which will guide you in diagnosing these patients. Because problem with diastolic dysfunction or heart failure with preserved ejection fraction is that these patients don't have a specific single diagnostic test. Like systolic dysfunction, we know that ejection fraction is on the lower side, the patient is having systolic dysfunction. But for diagnosing diastolic dysfunction, there is not a single parameter just on basis of which we can say that the patient has diastolic dysfunctions. So I will start with a case example. This is a common example which usually comes to our OPD, a common patient. She's a 60-year-old female, non-diabetic. She's hypertensive. She is obese of a BMI of 28 kg per meter square. And she comes to our OPD with breathlessness on exertion class 3 for 6 months. Now, how do you approach? Is it cardiac? Is it non-cardiac? Should we label it as her symptoms to obesity? Or there are certain parameters which we have to assess on echocardiography or other than echocardiography, which can help in diagnosing in these patients. So various terminology has evolved in diagnosing diastolic dysfunction in on echocardiography. In 2007, European Society and American Society came with the term of diastolic heart failure, which assess that the patient having a normal ejection fraction and they have diastolic dysfunctions, they have breathlessness. This terminology in coming few years because change into heart failure with normal ejection fraction, because it was seen that this diastolic dysfunction is not only limited to patients with normal ejection fraction, but it is seen in patients with systolic dysfunction also. Like in earlier talk it was presented, the patient is having systolic dysfunction, but they can have a diastolic dysfunction also on echocardiography. So normal ejection fraction was termed, but again, these patients sometimes may have normal or sometimes may have mild dysfunctions. So now in 2014, they came up with a terminology of heart failure with preserved ejection fraction. So this is the terminology, now the general terminology which has been used in diagnosing patients with having features of suggestive of heart failure, but these patients have a normal ejection fraction, that is ejection fraction of more than 50%. So it is said that the patient presenting with symptoms of heart failure, but his EF when we see is more than 50%. Now, how to assess that this failure symptoms or the breathlessness symptoms are due to cardiac problem? It's not pulmonary, it's not her obesity, it's not anemia, it is not other cause. That in few slides we will discuss. Now, why this heart failure with preserved ejection fraction is so important? The data have shown that the more than 50% of admissions, if we see in the emergency, this heart failure is due to preserved ejection fraction. And this is not a benign disease. It has a mortality which is similar to the reduced ejection fraction or maybe a little higher. And most of the time, these patients are misdiagnosed or underdiagnosed, and they don't get a proper treatment according to their symptoms. There are several triggers which worsen their symptoms. Either they could be uncontrolled hypertension, or the patient is non-compliant to the treatment, or most commonly patients developing atrial fibrillations or tachyarrhythmias, or patients having ischemias or anemia or chronic lung disease. These all comorbidities then again contribute to the worsening of the symptoms in these patients. So it becomes very difficult to diagnose these patients. Why? Because symptoms are very similar to other diseases also. It is not per se related to only diastolic dysfunctions. It can be due to your heart failure, reduced ejection fraction. It can be due to obesity. So it becomes very difficult to diagnose that this patient is having a heart failure with preserved ejection fraction. Challenges when we do these patients, the most common we go for an echocardiogram. And as already discussed in the earlier talk, ejection fraction is the most common, we can say the gold standard test which we use in assessing the breathlessness in the patient. If the ejection fraction is normal, we say, okay, the patient is having normal ejection fraction, his dyspnea cannot be due to cardiac. Or sometimes there are, we all know there are cardiac biomarkers which tells about the ventricular stretching or remodeling, like NT-proBNP, which is mostly elevated in case of reduced ejection fraction. But in case of diastolic dysfunctions, it can be normal or low. So again, we are again in a dilemma that whether this is patients having cardiac problem or is having a lung problem. Symptoms are very not specific. They can be overlapping with other diseases also. And sometimes the patient basal symptoms of filling pressure would be normal and they will be elevated only during exercise, and on rest it will be normal. So these are the challenges which we face. So according to these challenges, the ESC came with a consensus statement that if you're having a person with breathlessness, heart failure symptoms, you have to go for a 4-step protocol. That is your initial workup, followed by diagnostic workup. If still not diagnosis reached, go for an advanced workup and find the etiology or etiologic workup. So in coming slides, I will go one by one, what are the different modalities. So first and foremost is the initial workup. So when to suspect these patients having a heart failure with preserved ejection fraction or diastolic heart failure? First symptoms, most common will be the dyspnea, seen in 98% of cases, followed by exercise intolerance, seen in 59%, and edema is less common, as seen in 45% of cases. But when we do the echocardiography in these patients, the ejection fraction should be more than 50%. And the most important, when you go for it, always rule out that the other causes of the structural heart disease is not present. So Key criteria, signs and symptoms of heart failure, near or near normal ejection fraction, and we have to document the diastolic dysfunction. Now, how to document diastolic dysfunction is the key in these cases. Now, we all know the diastole, if we see, it's basically a passive phenomena. If we see that the isovolumic relaxation followed by a oxytonic relaxation in a normal person. But what happens in diastolic dysfunction? The isovolumic relaxation is decreased, or the compliance of the heart is decreased, leading to the increased left atrial pressures, which lead to increase in wedge pressures and leading to breathlessness. So how we can assess this LV diastolic dysfunction either by invasive method or by non-invasive method. Invasive methods, we can go for a cardiac catheterizations in these patients, and or a non-invasive by echocardiography. Now, invasive, we don't want every patient coming to our OPD going for invasive method. So we usually go for echocardiography in these patients. So you saw the patient, you got her X-ray done. X-ray is again not a very diagnostic test in these cases because it can be having cardiomegaly, it can show PVH, or it can be normal also. ECG, again, not very diagnostic. You can get varied presentation. It can be left ventricular hypertrophy, you can have atrial fibrillation, or it may be normal. So coming to echocardiography. Now, echocardiography, if we see, there are the different diastolic function assessment, which we go for it. First is the most, as we all know, we go for a mitral inflow. We see the E and A wave. Then we go for a TDI, as it was discussed, we were discussing in earlier lecture, that the tissue Doppler imaging becomes very important in cases of patients with diastolic dysfunction. In what happens in diastolic dysfunction, we know that during diastole, there is impaired relaxation. So the myocardium gets stiff. Now, E and A are the diastolic waves. So whenever there is diastolic dysfunction, the E velocity or E dash velocity, it decreases. Whereas if we see the E mitral inflow, it remains the same. So E by E dash ratio, it increases significantly. That becomes a diagnostic test for assessing these patients. So if we get a E by A ratio less than 8, it's a normal filling pressure. We can say, no, this patient doesn't have diastolic dysfunction, but we cannot rule it out, because I will tell you few scenarios if we can get a normal E by A dash ratio. If it is more than 14, it is definitely diagnostic, it's elevated filling pressures. But again, this E dash, it's not reliable, especially in patients having a mitral annular calcifications or in constrictive pericarditis or mitral valve disease. So the second modality which we can use is your LA volume index. As we know, diastolic dysfunction lead to increased LA pressure, leading to increased LA volume. So the biplane method more commonly used is the assessing the LA volume in these cases. Third important parameter which we can use is the pulmonary vein Doppler, in which we can see the AR or the reversal of the A wave in the pulmonary vein flow. And you can go for a color flow mapping, in which the velocity propagation can be seen. In case of diastolic dysfunction, the velocity propagation is delayed and it is less than 45 milliseconds. So these are the different parameters which we have to see on SS on echocardiography for assessing the diastolic dysfunction. So in 2016, ASC presented with their criteria for assessing the diastolic dysfunction. Whenever you go for ejection echo in these patients, go for ejection fraction. If it is more than 50%, go for assessing the diastolic function. We go for 4 parameters. First and foremost, go for a septal E dash or lateral E dash velocities. In diastolic heart failure dysfunction, they will be decreased. Go for E by E dash ratio if it is more than 14, or there is PA pressures are elevated by TR velocity more than 2.8, or the LA volume is increased as 30 ml per meter square. If we are getting more than 2 or more than 2 positive, that means that is diastolic dysfunction. You don't have to go for any other further test. But if it is less than 50, you say that it is normal. And if it is only 2 parameters are positive, rest are not, that it is a indeterminate. In cases of indeterminate, we can go for your global longitudinal stain and the TDI by septal dash velocities. So once the diagnosis of diastolic dysfunction has been made, we have to see what is the severity or the grading of diastolic dysfunction. If the grading, if we see that E by A is less than 0.8 and E is less than 0.5, it is a grade 1 diastolic dysfunction. That is, A is more than E and the velocities of E are less. So there is a mild LV, LA pressures are normal and there is a mild LV diastolic dysfunction is seen. If it is a restrictive filling pattern in the form of E is much more than A, it is more than 2, it's a grade 3 restrictive filling pattern. The problem occurs whenever there is your E by A falling into intermediate category. Then we have to use other parameters in the form of your pulmonary vein systolic by diastolic ratio. If it is less than 1 or the AR duration is more than the A wave, then you have to go for your diastolic dysfunction in these cases. But again, these parameters are not always very confirmatory. As already told, whenever there is, suppose it's a young patient, this E by A ratio, because the velocity across the mitral valve is increased, so they can have a normal finding of E by A. And especially in elderly, there may be impaired relaxation. So E by A ratio E by A would be less than 0.8, may be normal. And these velocities can hamper in cases of your having mitral annular calcifications. So what else can we go for in these cases? Suppose the patient is having atrial fibrillation, then again it becomes difficult to assess the diastolic dysfunction because the A wave will not be visible in these cases. So when the A wave is not visible, then we go for your TR velocities, going for your deceleration time, or you go for a E by E dash ratio in these cases. Now, so many parameters, so many confusions. So which parameter to be used? It has been seen these parameters are not very specific and it is not seen in all the cases. Like assessing the pulmonary vein velocity in these cases, hardly, if you go for real world scenario, only 30% cases will have a adequate pulmonary vein velocity signals. If we go for a E dash velocities, sometimes the E dash velocities can be seen in only 80 to 90% of the cases. Still, the patients are having a dilemma whether these patients have diastolic dysfunctions or not. So the other parameter which should be going for is you're going for a cardiac biomarkers. The most common cardio biomarkers for assessing the heart failure is the natriuretic peptides. We all know. We either go for a BNP or NT-proBNP. But in these cases, again, it creates a problem. Because we know with BNP and NP levels, they changes with age. When the BMI is more, their value is less. In females, they are a little higher. In renal dysfunctions, they are a little higher. And in atrial fibrillation, they may be higher in presence in normal diastolic dysfunction also. So this was a study which evaluated the patients with the BNP and heart failure with preserved ejection fraction. And for their surprise, 20% of the patients who was admitted in preserved ejection fraction, they had a low BNP. So the BNP cannot be also a gold standard test to assess these patients. So the ESC came out with a score. Just on one parameter, we should not diagnose diastolic dysfunctions in these cases. They said we have to look for a whole clinical demographic profile in these patients. So this is known, short acronym known as H2FPEF. H2 is heavy or hypertensive, that is obese and hypertensive, or the patient has atrial fibrillation, or PH is documented by echo. He is elderly and the filling pressures when assessed by E by E dash is more than 9. If it is the Z score is 0 to 1, it is unlikely that it is a heart failure. If it is score is 6 to 9, it is sure that the patient is having heart failure with preserved ejection fraction. But again, the gray zone 3 to 6 becomes a problem. And about 40% of the patients falls under this gray zone. So when the gray zone happens, then again, we have to go for some other test. So when the gray zone is there and still we are not able to diagnose, then the test we have to go for is a diastolic stress echocardiography. In this, we assess these patients may be normal at rest, but when we ask them to exert, these parameters of diastolic dysfunctions become overt. So what we ask the patients to do, we do the echocardiography, we ask the cycle ergometry to see in the patients, we increase the protocol by 25 watts every 3 minutes and assess the mitral inflow velocity and the TDI velocity of the mitral annulus. In a normal person, both E and E dash will increase, so the E by E dash ratio will remain the same. But in cases of your heart failure patient, the E dash will remain the same, but the E velocity will increase, so the E by E dash ratio will increase. So if the E by E dash increases by 15 or the TR velocity increases by 3.4, the patient has heart failure preservation fraction. But if it is still not increased and we are very sure that the patient has dyspnea due to cardiac, then you have to go for a invasive test in these cases. Invasive, usually we have little inhibition going for invasive until under very high suspicions. So we go for a left and right heart catheterization in these patients. We ask the patient to do at rest, we measure the LVDP wedge pressures. If on rest it is elevated, then nothing to be done. But if it is normal, then we ask the patient to do stress in the either form to move the arm or the legs. And if it is elevated, LVDP increases, then these patients, that means we have to suspect that these patients have your heart failure with preserved ejection fraction. Certain novel parameters have been evaluated on these cases, like LV global longitudinal strain, diastolic strain rate. These have been shown to be decreased again in these cases, but again, not a very diagnostic or a gold standard test. A new parameter of apical untwisting has come up, which I will not go into detail, but these have been shown that since there is basically a diastolic relaxation disturbance in these cases, the untwisting in these patients are decreased. So it becomes a high suspicion in these cases. And the LA strain rate is decreased in these cases because of increased LA pressures. So coming back to my example, this patient, 60-year-old female, she is non-diabetic, she is hypertensive, she has a BMI of this. So now I want to go proceed for it. So I will get an X-ray run. Suppose her X-ray comes of CTR ratio of 50%, no cardiomegaly, her PVH is normal. So I know that we can't rule out heart failure with preserved ejection fraction. I will go for ECG. ECG is normal. Again, it's not very contributory. I will go for echocardiography. Now in echocardiography, I find her ejection fraction to be more than 50%, but her E by E dash ratio is only 10. That again not favors that it is going for a patient having marked diastolic dysfunction. So my total score came out to be 3. I don't know, I will go for a BNP level in this case. Suppose the BNP is only 80 picogram per ml. Again, this is not very contributory, but the patient gives classical symptoms of class 3 dyspnea. Then the score of 3, it is falling into gray zone. We should go for a stress echocardiography in these cases, going for a cyclohygrometry. And if stress echocardiography shows that E by E dash increases more than 14, then this patient is having a heart failure with preserved ejection fraction. So my patient developed E by E dash more than 14 after exercise on stress echocardiography. So I went for a treatment. So what are the treatment which have to use specific in these cases? First and foremost, we have to rule out the etiology. If she is hypertensive, we have to give antihypertensive. No specific antihypertensive has been shown to be superior in these cases. Patient, if they have atrial fibrillation, these patients' atrial fibrillation should be controlled. If we document any myocardial ischemia in these cases, the myocardial ischemia is also a very important cause for diastolic dysfunction. That should be addressed in the form of coronary angiography and revascularization. Suppose the etiology, no etiology comes out, and this is pure case of heart failure with preserved ejection fraction. So what are the specific treatments which we can use in these cases? Mineralocorticoid receptor antagonist or aldactone, which is spironolactone, which we usually use in our practice. TopCat trial was shown that this doesn't have a very specific cardiovascular mortality benefit in these cases, but the sub-analysis showed that there is decreased hospital admissions if we give a aldosterone antagonist. Diuretics, if the patient is having volume overload symptoms. The treatment which is for reduced ejection fraction which have shown a very mortality benefit. Unfortunately, with preserved ejection fraction, these drugs have not shown any added benefit in these cases in terms of mortality and hospital admissions. So the beta blockers, ACE inhibitors was assessed in the different trials. The perindoperitoneal trial, PEP-CHF was used. For ARBs, ibicitan was used. Recently, ARNI Paragon heart failure was used in normal heart failure preserved ejection fraction. But none trial shows a mortality benefit in these cases. Only subgroup analysis have shown that there may be a decrease in hospital admissions. So no specific treatment still now has been shown to giving these patients. Certain investigational therapy which are being done are atrial septostomy. The basic mechanism of atrial septostomy has been shown that the LA pressures are higher. So if we go for a septostomy in these cases, we might debulk the LA pressures and the patient's symptoms by maybe decrease by decreasing the wedge pressures. So in concluding my talk, if for assessing the heart failure with preserved ejection fraction or the diastolic heart failure, the clinical and demographic data should be considered. The patient should be seen as a whole patient, not on just one parameter. We have to assess all the parameters of diastolic dysfunction. No single parameter is a gold standard parameter, either in form of the biomarker or the echocardiographic marker. After diagnosing diastolic dysfunction, we have to assess the grade of dysfunction, whether it is grade mild or grade 2 or severe grade 3 restrictive type of filling pressures. And these should be acknowledged and taken seriously, because the mortality, when they compare with preserved ejection fraction with the reduced ejection fraction, is similar or the little higher. And when we are still in the dilemma, we should consider invasive and non-invasive stress testing in these cases. Thank you.
Yeah, excellent talk, Dr. Rupali. This is Dr. Mukulesh. And a couple of queries and concerns regarding this very commonly prevalent condition which we encounter day in and day out. But because in most of the echocardiographic reports, what we see is simply E and E prime ratio. So just wanted to know what is the specificity and sensitivity of E prime, because other parameters are normally not done on routine echoes, what we see in day-to-day practice. This is point number one.
Yes, I agree with Dr. Mukulesh. See, as shown in my talk also, this E by E prime ratios, these are our sensitivity of 80%, specificity of 85%, but still they, sensitivity of 60% and specificity of 85%. So these are not very sensitive markers. We can clearly rule out that these patients have heart failure with preserved ejection fraction. So just E by E dash will not help us. We have to look for the LA volume index. We have to look for TR velocities in these cases. We have to look for the individual E prime velocity of these. Then only we should diagnose these patients to have diastolic heart failure.
Yeah. The second question is regarding the problem solution, because we encounter with diastolic dysfunction in very commonly in diabetics. And now the question is of treating them. Now, evidence has seen and given us that insight that most of these therapies which are very effective in heart failure with reduced ejection fraction are not of use in diastolic dysfunction with left ventricular preserved ejection fraction cases. So what specific therapy can we see using in our patients? And what is the role of SGLT2 inhibitors, or maybe because the pathophysiology is hovering around the inflammation in the preserved ejection fraction. So do we see some sort of addressal in form of anti-inflammatory mechanism or therapy for treating the preserved ejection fraction?
Yes, I totally agree with you. See, the therapies, because if we see the reduced ejection fraction have shown many therapies which have shown to decrease the mortality and morbidity in these patients. And if we see in the past 30 years, the mortality due to reduced ejection fraction have decreased. But if we see the preserved ejection fraction, the data have shown that the mortality, there is no difference. What was 30 years earlier, it's same as 30 years now. So that's unfortunate thing. Not a single trial have shown that we can use this, any drug which has shown to decrease the mortality. We have to go for a symptomatic treatment, whatever it is. If it is a patient is having symptoms of LV volume overload symptoms in the form of either the patient is having PA pressures, high PA pressures, we have to go for a diuretic treatment in these cases, and or go for a spironolactone study was done, which sub-analysis showed that in TopCat, that subgroup analysis, it might decrease the hospital admissions. So we have to go for these spironolactone antagonists in these patients. The second part of your question was whether your SGLT2 inhibitors, since there is no data at present with the preserved ejection fraction, so it is not recommended going for in these patients going for preserved ejection fraction. The third part, anti-inflammatory, I agree with you. The basic mechanisms in these diastolic heart failure, all the heart failure preserved ejection fraction has been shown that there is increased extracellular matrix in the myocardium, the collagen is increased, there is increased inflammatory interleukins in these patients, the pro-inflammatory markers are elevated. But since now there is no trial which has been directly targeted on this to decrease it. So clinical practices, there is at present no treatment which is, I would say, that is specific for it.
Thank you so much. And once again, complimenting you for comprehensively covering this difficult and a very common problem. Thank you so much.
Thank you.
Dr. Rajat Jain, is there any question from the floor of the house?
Dr. Rupali has covered very nicely this topic, and she is very right in saying that this is not a milder form of CHF. It can produce same level of symptoms or severity of symptoms as systolic heart failure. And I think it is the management of mainly comorbidities associated with these type of patients which should be treated rigorously to control symptoms of
Okay, thanks a lot, Chairperson. Due to paucity of time, we are going to our next session, that is clinical utility of echocardiography in COVID patients with strain imaging. The speaker will be Dr. Nandita Chakravarti, who is very good echocardiography at Calcutta, and I know her personally because we did our echocardiography course at Delhi together under Dr. Rakesh Gupta. The chairpersons are Dr. C.R. Rawal and Dr. Sunil Jain. Dr. C.R. Rawal is an eminent cardiologist at Agra, practicing very well. And the other Dr. Sunil Jain is a very eminent cardiologist and professor of cardiology at Jhansi, MLB Medical College, Jhansi. Jaipur, SMS Medical College, Jaipur. He is a very prominent cardiologist there. He is having very good reputation. He is a very good researcher and very good echocardiographer. Now, I would request Dr. Sunil Jain to introduce the speaker and proceed with the talk. Thank you very much. Dr. Sunil Jain, can you hear us? Yeah, we can proceed with the talk. The panelists in the talk are Dr. Rakesh Jalota, Dr. Rekha Mishra, Dr. Nirupam Prakash, and Dr. Dinesh Kumar. Dr. Jalota, can you introduce the speaker? Dr. Rakesh Jalota, can you introduce the speaker? हमें लगता है कनेक्ट नहीं हुए क्या होगा?
Jalota sir is connected. 1 second, I'll just check.
Yeah, I think the chairpersons are not connected.
Chairperson sir,
Dr. C.R. Rawat and Dr. Sunil Jain. Yeah, Dr. Nandita Jain, you can proceed with the talk right away.
Thank you. Thank you, Dr. Rajiv. It's good to see all of you after such a long time. And good to see that everybody is doing well in this COVID-infested era. Now, why the first thing that we would like to talk about, why is the concern regarding COVID patients with comorbidities and cardiac, especially with cardiac involvement? We first started out, we were looking at COVID. COVID seemed to be just a pneumonia and affecting the lungs. But as time progressed, we realized that cardiac involvement is common in COVID patients. Patients with existing cardiac risk factors are more prone to catch the COVID infection. And patients with these comorbidities have a more severe disease with a worse clinical outcome. And several studies, a meta-analysis showed that whereas overall fatality rate in normal patients was only 2.3%, but patients who had already pre-existing cardiac disease, it rose to 10.5%, and it settled at somewhere around 7 to 8% in patients with pre-existing hypertension. So it became a cause of concern because we wanted that these patients should be treated with more care and more vigilance so that we do not have increased morbidity and mortality. Now, there are multiple mechanisms of cardiac damage which have been identified in COVID. A cytokine surge, which results in injury to multiple organs, including cardiac myocytes, happens. There's a direct myocardial injury happening because of the coronavirus, which tends to sit on the ACE2 receptor sites and penetrates the cells. Because of pneumonia and because of oxygen hypoxemia, there's an oxygen supply mismatch for the myocardial tissue. There's a huge systemic inflammation happening and this catecholaminergic surge. So plaque rupture leads to ACS or frank myocardial infarction. Electrolyte disturbance, especially hypokalemia, causes arrhythmias. Coagulopathy occurs in patients with COVID, and the medications that we give now for COVID also have side effects which worsens this scenario. Now, who are the patients we need to be vigilant about? COVID affects more the middle-aged and the elderly, and these patients are more vulnerable. Males are affected more than female patients. Medical comorbidities, as we have told you, worsen the situations. Diabetics are more prone to worse outcomes and concomitant infections. Kidney disease, pulmonary disease, cardiac disease, all these comorbidities are the patients who are more vulnerable and are likely to have worse outcomes and more mortality and morbidity. What do we want to evaluate? Now, these patients present with anemia, lymphopenia, hypoxemia, abnormal kidney and liver functions, elevated creatinine kinase, D-dimer. There may be thrombocytopenia. LDH and prothrombin time may also be deranged. TROP-T, NT-proBNP may be raised in patients who are having cardiac damage, and inflammatory markers are also raised. The more the elevated ranges and the more prolonged these lab tests are abnormal, the worse is the outcome of these patients, and we need to be very vigilant about them. What to evaluate in imaging? Chest X-ray is a must and gives us the basic, basic picture of the patient. If the chest X-ray indicates, then a chest CT also should be done to see how much of lung involvement is present. Transthoracic echo is the modality of choice to look at heart function and follow-up of patients who have had some kind of cardiac event or cardiac involvement. Cardiac MRI may be done in cases with whom we are not sure about what we are seeing on transthoracic echo, or they are not presenting with familiar symptoms. Now, who are the patients who will choose for transthoracic echo? Overtly, if a patient is in heart failure, arrhythmia, ECG changes, cardiomegaly on chest ray X or CT, these patients are candidates for transthoracic echo right away. The some patients who do not present with any of these frank symptoms or signs, but they have these persistent tachycardia and persistent, persistent SOB or discomfort or dyspnea on slightest of exertions. So these patients are also candidates for transthoracic echo, because transthoracic echo will show us whether there is any abnormality happening. Now, how to get the maximum of information in COVID patients, because usually they are bedside echoes and we are not able to bring them to the department or even take a high-end machine to the bedside. And the resource challenge is a very major issue. We do not have machines, we do not have personnel. And even if we do have machines, then those machines are not very high-end machines. So we have to make do with information which is very, in terms of information, it is not a very resourceful entity. So maybe we are only able to look at systolic function, any morphological changes or any wall motion abnormality, global hypokinesia, and in some cases we are able to do some tissue Dopplers. But beyond this, we are not able to go in most COVID patients because of resource challenge. However, which we are doing with good personnel and getting good images for these patients, we will definitely get some information as to which will tell us how to proceed in the case of patients or whether the patients have at all a cardiac involvement or not. What are the cardiac complications that we could be looking at? Now, ACS due to plaque rupture or MI, acute myocardial injury could be one of the things. Myocarditis, which is secondary to COVID itself, could also happen. Heart failure because of either of these two is a possibility. Hypokalemia, as well as the drugs that we use because of to treat COVID, sometimes give arrhythmia to these patients. And last but not the least, we may also be looking at pulmonary embolism in these patients. So each of these complications will have a different kind of presentation in the echocardiography and the clinical scenario. So we could distinguish what is happening to the patient by putting together his symptoms, other modalities, and the transthoracic echocardiography and get a good answer to why exactly the patient is having the morbidity that he or she has. Now, what are the things that we might have? Now, left ventricular wall motion abnormalities is in a study done with evidence of myocardial injury in COVID-19 patients. They found that about 25% of people had left ventricular wall motion. My screen went off.
Sorry, ma'am. Again, requesting you kindly upload the slides, please.
Yeah, okay.
Yeah.
Yeah, I'm there. Please give me a minute. Yeah, so 25% of patients were having left ventricular wall motion abnormality, indicating they had ACS or acute myocardial injury or MI. Now, diastolic dysfunction was present in about 10 to 15% of the patient. Right ventricular dysfunction occupied almost 30% of patients had right ventricular dysfunction, with 20% of patients having LV global dysfunction or myocarditis. Pericardial effusion appeared to be of universal presence in all these patients, and we could get the pericardial effusion in any of these or
Ma'am, requesting you again join. May I request Jalota sir? Yeah, ma'am. Please carry on, ma'am.
Yeah, pericardial effusion could be present with or without any other comorbidity, and there have been cases reported where pericardial effusion was so severe that it led to tamponade and it had to be evacuated to give the patient relief. Now, cardiovascular manifest, in our Indian experience, we find that most of the patients are having pericardial effusion with or without other existing comorbidity in the cardiac scenario. This is a echo which is showing the pericardial fluid all around the heart. And this is not a very significant amount, so these patients don't require anything, but also there is the presence of systolic dysfunction in this patient. So this patient is probably a patient of myocarditis with pericardial effusion. So even if you are not treating the pericardial effusion, you will have to institute treatment for myocarditis and follow the patient up appropriately. If you look carefully, you will see that this patient has a wall motion abnormality, which is in the near the apex. See, if you look here, there is a distinct wall motion abnormality when compared to the septum here. The septum and the apex are both compromised, and this patient has ejection fraction of maybe a 40%. This is an example of an acute myocardial injury or myocardial infarction which has happened. The patient also has some amount of pericardial effusion, as you can see from the subcostal view. This again is not, though there is right ventricle appears to be collapsed, you can see that it's a systolic, it's not a case of tamponade. A coronary angiogram of this patient revealed that the patient was having 100% proximal LAD stenosis. Now he was dealt conservatively and recovered. Now this echo is showing that there is some amount of ejection fraction is almost normal to be 50, if eyeballing it might be 50% or more, but there's a significant reduction in GLS. You can see that this part of it is normal and the rest of it, here it is significantly reduced, and the other segments also are showing a reduction in GLS. So this is a case of myocarditis with most of it is subclinical as yet, but this patient could go either way, becoming frankly, cardiomyopathy, presenting as a frank cardiomyopathy, or could recover and become a normal patient. So this patient would need a follow-up and also would need appropriate therapy. This is again a blown up this thing where you can see that 18%, 22%, 20% is here, but you've got 15, 12, 11, 9, and all these, segments are compromised. So here you have almost a normal ejection fraction with a significant low GLS. Right ventricular involvement is a very dreaded complication of the patients with myocardial injury in COVID-19. And most of these patients do rather badly. And most of these patients who are, if you look at them, who are on invasive therapy like ventilation and ECMO, are those patients with right ventricular compromise or right ventricular failure. Here also, you can see that the right ventricle is somewhat enlarged and right atrium is also enlarged, and there is the right ventricular strain also is compromised. Now, right ventricular dysfunction could exist with or without involvement of the left ventricle. If it is with the involvement of left ventricle, then the scenario, of course, is more threatening. But in itself, the right ventricle, till it recovers and till it gets back to its normal function, it can be a severe challenge for treatment. This is the other complication of COVID, though not directly related to the heart. It definitely affects the heart. This is caused by pulmonary embolism, and you can see that the PA pressure is elevated and PVR is also elevated. And these patients have to be treated with anticoagulants and supportive therapy till they do well. In fact, we have seen quite a few patients in our experience, those who have had pulmonary embolism or have developed pulmonary embolism in their course of hospital stay, have been compromised with high counts of morbidity and mortality. So this is quite a dreaded complication. In fact, microvascular involvement is there in COVID in many organs, and it continues even beyond the period of COVID, the actual morbidity of the COVID. And it is a dreaded complication which can happen. This thing, I do not have the slides, but I actually saw a case of COVID involvement with involvement of the coronary arteries. She was a young girl of about 25 to 30 years, and she was having this persistent tachycardia. And when we did an echo, we found that both her coronary arteries were measuring almost 7 to 8 millimeters, and they were a fusiform involvement was there. But unfortunately, we were not able to preserve that echo for ourselves. So here you would also see that those of these patients who have a right ventricular involvement, they might have IVC which is dilated and which has a lot of contrast. Sometimes you may not be able to get the PA pressure also because of right ventricular dysfunction. But if you get a picture like this, then definitely something is wrong in the trajectory of the inferior vena cava. Treatment of choice. Actually, PCI is no longer the gold standard because in COVID patients, because there is a lot of health personnel involved and there's a lot of shedding of virus during these times. So thrombolysis and acute MI, supportive therapy in subclinical cardiac involvement. Small effusions, as I said, disappear. Pulmonary thromboembolism has been treated adequately, and severe cardiac involvement may require invasive management. What to do with patients who come in with comorbidities? If patients are on certain drugs and they are doing well on that drugs, there is no immediate cause to discontinue the drug therapy and start something other than that, unless there is a call for it. So those drugs can be continued with careful monitoring with side effects. Even patients who are in home isolation and they are not coming into the hospital can be monitored offline or online to see whether they are doing well on their drugs. Until and unless there is a real cause of concern like overt heart failure or overt arrhythmias, there is no cause for admitting these patients per se for myocardial damage. Vigilance is good enough. Sometimes we are giving drugs which are additively causing some, arrhythmias or prolonged QT intervals. In those cases, we need to withdraw whatever new additions we are giving and give drugs which will not cause these problems. So regular and routine ECGs are also important in these cases. The disease doesn't leave you even if you are becoming, RT-PCR is negative and you have stopped, you have become normal. Post-COVID, a lot of patients are coming up with CAD, myopericarditis, and heart failure with preserved ejection fractions. Even if you cannot estimate tissue Dopplers or this thing, a simple LA analysis will tell you bedside whether these patients are having heart, HFnF, and appropriate treatment can be instituted. Once they are offline and post-COVID, they can be brought to the labs and we can look at their echoes properly with all the modalities and decide whether these patients are going into prolonged myocardial injury or myocardial involvement, and accordingly we can treat them. So conclusion is that we are still in the midst of this battle and it's getting only worse because as we go along, we're discovering more and more things about COVID, what it can do pre, post, and during its presence in the patient. All patients are COVID suspect unless proved otherwise for the physician, because you never know who has come in with an asymptomatic COVID, and you should be careful both for the patient and for yourself. So beware of that. And any planned procedure which requires echocardiography to be done should be done only if the planned procedure is also a very important and urgent one. But we also need to wear protective gear and keep ourselves, away from danger. If you want to, if anything like semi-invasive procedures are required for a patient, then it is best that best protection protocols are taken into consideration. And until and unless it is an absolutely need of the hour, it is best to avoid them in COVID positive and active patients. So strain, we have myocarditis, heart failure, which complicates and prevents us from assessing how much of it is, respiratory involvement, or how much of it is cardiac involvement. So, and we don't have time for settling down the patient in these cases, because this can get worse and we will have to take a call on how we can do this thing. 2D strain is usually not available bedside, and therefore, we are unable to do these things. But a TROP-T would give us good answers. A TROP-T, if combined with a strain imaging, would definitely pick up, myocardial involvement in those patients who are still having good ejection fraction. Now, RA and RV view, focused RA and RV view would give us a good insight into whether right ventricular functions are deteriorating and whether pulmonary involvement is there and pulmonary embolism has happened. Pericardial effusion, if mild, we just need to follow up. And acute myocardial infarction and other cardiac involvements. Other cardiac involvements are supposed to be. Just please give me a second. So basically, we are looking. A lot of patients have cardiac involvement, and the people we see who are having active cardiac involvement are only the tip of the iceberg. So a careful evaluation is necessary, and a careful follow-up is also necessary to make sure that these patients do not go into sustained heart failure and other kinds of myocardial damage. I would just like to finish my talk with thanking Dr. Rakesh Gupta, who gave me a lot of inputs into the study that they did in GEROP. And they have followed up a lot of COVID patients and looked at a lot of COVID patients in their center. And they have a good insight into what's happening out there. As for our experience in the hospital, we see a lot of cardiac involvement, more than that is globally accepted or projected. And these people, many people with cardiac involvement, are almost 30% of the patients who have cardiac involvement are going in for further deterioration, increased morbidity and mortality. Thank you.
Thank you, Dr. Nandita, for such a recent and elaborate talk. Welcome, Dr. Rakesh Jalota. You are now not only panelist but chairman of the session. What is your experience regarding this talk? Have you got any query?
Well, it is very nice. It has been very nice deliberation of COVID and cardiac involvement. She has given very detailed, and it is very eye-opening, because most of the people, as she told in the beginning, were only thinking that COVID only gives you pneumonia and lung involvement. People were little ignorant, because I have also seen many times, they only talk about pneumonia and nobody talks about the heart. And really, it gives a big insight that you must also look for the prognosis of the patient also depends upon the cardiac involvement as well. And so that accordingly timely treatment is given, then patient will definitely benefit. It is very nice.
And Dr. Nandita, you can entertain any question from the floor of the house.
Yeah, sure.
We are waiting for the questions. Can I ask you one question?
Yeah, sure.
How to differentiate acute myocardial infarction and myocarditis, especially in COVID patients, by echocardiography? And number two, after post-COVID, if the patient is COVID negative, would you continue treatment lifelong, or will you stop the treatment after some time? If the patient develops acute MI, if the patient develops congestive heart failure, if the patient myocarditis, how long we should continue the treatment after the post-COVID injury is almost relieved?
I'll answer your first question, distinction between myocarditis and myocardial ACS or MI. In MI, we would not expect global involvement of the myocardium. We would be looking at, injury to a specific CAD territory, coronary artery territory. So we would be like we saw in this thing, there was the distal septum involved and the apex was involved, and the rest of the myocardium was contracting almost normally. So this is one of the hallmarks of this thing, that if you have acute MI, then we would look at a territorial involvement. That's one thing. In myocarditis, it sometimes does look like there is territorial involvement, but what happens is you will find a global scenario with some contractility preserved in some segments, but usually it doesn't happen with just one segment as in an acute MI. So it will be, maybe you will be looking at the inferior. It usually happens, in my experience, I've always seen that the inferior-posterior wall sometimes keeps on contracting well in spite of the rest of the myocardium being depressed. So you could think, sometimes in sepsis, we see that the basal walls and mid levels, they're all hypocontractile, while the apex is contracting very well. So these are the pitfalls, but they will definitely not conform to a coronary artery territory. That's one thing. The second thing, that how long will you follow up? Now, frankly speaking, COVID is still happening and we are getting inputs about every day the input is changing. As of now, the guideline is if the patient is symptomatic or if the patient has given you some parameters which are abnormal, keep following up the patient till you are perfectly sure that the patient has reverted back to normal. Like a patient with a compromised GLS has come up to a normal GLS and is having a good ejection fraction. Now, I would say, even this is personal and not this is not supported by anything, that even after you get a good GLS and this thing, you should keep following up the patient for some time, because in other cases of myocarditis, our experiences, we have seen people come up doing well and then going back to their previous state without any pertinent cause. So I would say that just follow up for a while. And the biomarkers are very important. The biomarkers, like for example, there's a pulmonary embolism patient, his D-dimer is high and the D-dimers are coming down and everything. Heart failure patient, NT-proBNP is normalizing, patient is doing better, tachycardia is coming down. You can withdraw medication and still the patient is doing well. So all these things will give you a guideline as to how often you want to follow up a patient or not. We still don't have data coming in. As far as COVID is concerned, data is very punitive. Like, even when they do a cohort study, they maybe have a few hundred patients, and that would be 300, 400 patients. It's not like we are looking at thousands or lakhs of patients, even though there is no dearth of patients. People haven't managed to get the data. So once data starts coming in, we will know how long they really need follow-up or how long they're really being sick. It requires time.
Thank you, Dr. Nandita. You have done a real justice with the topic, such an unexplored topic, recent topic, but you have given a very elaborate knowledge. Thank you very much. Now, I would thank Dr. Rakesh Jaluta for acting as a chairman in this session. And I am thankful to all the panelists. Now, I would hand over the mic to Dr. Sajid Ansari for the next session. Thank you very much.
Samir, Mr. Samir. Yeah.
Yes, sir. Yes, sir. Slides are visible.
Yeah. Should I start? Okay.
Yes, sir.
Welcome to all my senior friends. Now it's going to start the topic in the part little bit more clinical. Now your cardiography session is finished. So coming to clinical cardiology session, and starting with a very big name all over India and abroad, Dr. R.M. Gokhru. And for this, we have Chairperson Dr. Virender Singh and Dr. Manoj Kumar Srivastava from Faizabad and Lucknow. And we have panelists, Dr. Rajat Mohan from Kanpur, Dr. Sanjay Arora from Lucknow, Dr. Muklesh Gupta again from Lucknow, and Dr. R.R. Singh from Jhansi. So, Dr. Virender Singh sir has joined it. Please welcome Dr. Virender Singh. He is renowned physician and diabetologist from Faizabad, Ayodhya, and he is very close to me, my close seniors. and very academic and involving so many conferences. He is president of UPAPI, past president of UPDA. Over to you, sir, to start our.
So, good evening, gentlemen. Now we have very important topic, metabolic modulations in angina. And to do justice with this topic, we have very renowned stalwart speaker, Dr. R.K. Gokhru, R.M. Gokhru rather. He's from Ajmer. He's president of Indian Society of Cardiology. He's editor-in-chief, Indian Journal of Cardiology, and he has more than 275 research publications. He has been principal investigator in Azular study, Swimi study, EXMAS study, Ajmer study, Ajmer SID study, coronary sinus anatomy, Amar arch anatomy, CALD, and ARTEM heart failure trial. So I think I should not take much time. Over to Dr. Gokhru. Please, sir, continue with this.
Gokhru sir, may I request you kindly unmute yourself? Gokhru sir, may I request you? Please unmute yourself.
I'm able to.
Yes, yes. Now, in between your voice has come, but now again you have muted. Sir, requesting you kindly unmute, Gokhru sir.
Okay.
Yes, your voice is audible now, sir. Please go ahead, sir.
Okay.
Sir, if you can switch on the video also, people can able to see you.
Okay,
Yes,
fine.
yes. Thank you, sir. Thank you.
Thank you very much, Chairperson, for kind introduction. I'll be touching a very important topic about management of coronary artery disease or coronary ischemia, myocardial ischemia. Which slides going on? How do you change slides?
Sir, by just click the next button and your slide will change. On your laptop, there is a key. Next, click on that.
It's a MacBook, na? Coming.
So, yes, your
Okay,
slide
it's
is
coming.
changing now.
Yeah, absolutely perfect. So, as far as acute coronary syndrome, stable angina is concerned, we are well versed about the management in terms of balancing the demand and supply. So, if you want to manage angina, you have to manage the demand versus supply match. This mismatch is to be managed, and the demand is usually met with use of beta blocker, and the supply is met with vasodilators, primarily nitrate. Whenever any situation comes when you cannot cope up with the angina in spite of optimum utilization of beta blockers and nitrates, that is a stage, third line position, when you need some modulation in the myocardial cell to overcome the ischemic injury and the surviving the cardiac myocyte. So, in our routine, principal management includes oxygen supply by increasing nitrates and demand decreasing by beta blockers. When optimum therapeutic doses, beta blocker, heart rate reduced up to 60, still having angina. Nitrates given optimum doses, blood pressure approaching 90. You cannot increase the dose of nitrates. You cannot increase the dose of beta blocker. This is stage 1 where you can use the metabolic modifiers. These drugs do not affect blood pressure and heart rate. And actually the cell metabolism is improved and thereby the angina is supportively helped. If we see the ischemic position, as soon as the blood supply decreases, the intracellular acidosis occurs and there is a late sodium current activation. And this is the first position where there is increased sodium intake into the cell, which by sodium calcium exchanger causes loading of the cell by calcium overload. And this calcium overload is responsible for diastolic dysfunction and makes a substrate for many arrhythmias. At the same time, when there is ischemia, decreased blood supply, decreased oxygen supply, decreased substrate in terms of fatty acids and glucose to the cardiac myocyte, their functional efficiency decreases because of decreased ATP production. So the cascade starts first as soon as the blood supply falls. There is the activation of the late sodium channels, and this is for every change of calcium, there is 3 molecules of sodium they get in. And this sodium calcium exchanger causes loading of the cell by calcium. And this calcium overload is responsible for onset of dysfunction, initially form of diastolic dysfunction. There is a problem of diastolic relaxation, and then there is electrical instability because of the early after depolarizations. So many patients who continue to experience intractable angina despite being on optimal medical therapy. These are the group of patients where you need metabolic modulation for efficient ATP production, which may be the next subsequent logical step for relief of angina. And these are the group of patients who are either bridging for bypass surgery or who, because of comorbid condition, cannot have any intervention or surgical or pharmacomechanical intervention. These drugs, they play a very important role because they neither affect the heart rate and not the blood pressures. So if we see what is the position of these drugs in the management of coronary obstruction disorders, in the first group where there is a 50% obstruction, here the demand and supply, the 50% area is there to increase the blood supply to 5 times of coronary blood flow. So you can reduce the demand by beta blockers. So when the obstruction is nearing 50-60%, the first drug is the beta blockers to reduce demand. As the obstruction increases, we have to increase the blood flow itself by coronary vasodilatation. So addition of nitrate comes at a number 2. But as the obstruction further increases to 90-99%, at this stage, in spite of full therapeutic dose of beta blocker and nitrate, still angina, this makes the place for these metabolic modifiers, and these are the drugs we'll be talking about. Therefore, in 50 to 60% luminal diameter stenosis of coronary vessels, there is no need of metabolic modulation for treatment of angina because of epicardial vessel dilatation and demand reduction may be sufficient to alleviate angina because we have the space for increasing the beta blockers, space for increasing the nitrate therapy. But if the obstruction is more than 90% luminal diameter, which approximates to 99% of cross-sectional area, at this position, there should be metabolic modulation. So there is a shift in the pathway of metabolism from fatty acid to glucose because of the ischemia. because you cannot further dilate the epicardial vessels to increase the oxygen supply or reduce the demand. NICE guidelines have placed the role of these metabolic modifiers as a third line drug after using the first initial two drugs, beta blockers and nitrates. So if you talk of strategies for refractory angina, refractory we are talking in terms of only medical management, and these metabolic modifiers, they also make a part of pharmacotherapy in the current system as a third line drug. So actually the piece of metabolic modifiers in management of refractory angina, refractory in the sense our conventional body therapies are not able to control the angina. So it is the third line, and here they make a position that metabolic modulation by these drugs in the green. So if we come to exactly the cardiac, what is cardiac metabolism? In normal aerobic conditions, the ATPs, they are coming from the substrate-free fatty acids, which are responsible for giving 60 to 90% ATPs for cardiac contractile function. And 10 to 40% energy, it comes from carbohydrate. So the substrate is fatty acids. What happens in our condition during ischemia? There is a shift from free fatty oxidation to glucose metabolism. It is very important to understand that in spite of ischemia, still the free fatty acids, they remain to continue as a main substrate even in ischemia. And this is the culprit. Though in ischemia, the metabolism shifted to glucose, but the amount of ATP generated by the glucose is less as compared to free fatty acids. Secondly, the amount of oxygen requirement for this fatty acid oxidation is 10 to 15 times more. So if we block by any means this free fatty acid metabolism during this ischemia, you need less energy, 10 to 50% less oxygen need. So it is important to understand when ATPs are produced by these two pathways, how to block this free fatty acid during ischemic situation. If you look to the free fatty acid pathway, long chain fatty acid, once they enter to the cell, then they join the myocardial cell, they cross the myocardial cell wall and enter into the mitochondrium through the CPT1 and CPT2 enzymes. These are very two important enzymes which are to be blocked if you want to prevent the free fatty acid metabolism. And beyond that, next to that, the beta oxidation you have to block so that the TCA cycle, where the acylyl coenzyme enters to ultimately form the ATP, is blocked, and so the whatever extra free fatty acids who are making contribution in spite of hypoxia, they do not produce intracellular acidosis and the cascade of calcium overload. So this can be very well explained during aerobic situations when there is subcortical ischemia of the myocardium. Still, myocardium continues to derive a large proportion of its energy from oxidative metabolism of free fatty acids. But as soon as the obstruction becomes more than 50%, the contribution of carbohydrate to glucose increases, fatty acid decreases, and whatever ATPs they are more coming from the glucose as compared to free fatty acids, and the less of ATPs are produced. To compensate these ATPs, free fatty acids continue to go for metabolism. So ultimately, we have to block this free fatty acid metabolism because it is going to cause formation of increased pH in the cell, ischemic cell. So there will be intracellular acidosis and then increased calcium load. So both the diastolic dysfunction and intracellular acidosis causing dysfunction of the contractile function. This is the most important slide of all to understand where these our drugs are going to modulate the function. This is your mitochondrial membrane where CPT1 and CPT2 enzymes are there. These are the two enzymes, they block the entry of free fatty acid into the mitochondrium, and inside the mitochondrium there is a beta oxidation to form the acylate coenzyme A. Here, this beta oxidation is prevented by our drug, and hence the free fatty acid metabolism is reduced, so the acidosis is reduced, and it is supplemented by the glycolytic pathway by oxygen. So our objective here in ischemia is suppression of free fatty acid uptake, that is here CPT1 and CPT2 enzymes to be inhibited, and then suppression of free fatty acid beta oxidation inside this mitochondrium. The beta oxidation is to be stopped. So our drugs will be working here. This trimetazidine is the one which is block this pathway intracellularly, and the other drugs which are available but not in clinical use, much clinical use because of their limitation we'll be talking, is CPT1 and CPT2 enzymes, is perhexylene and etoximer. We're gone.
Sorry, sir, your screen got disconnected. Requesting you once again, kindly upload your screen.
Yes.
Rakesh.
It's not changing. Okay. So, what is the scope of our metabolic modifiers in the management of refractory angina or angina which is not controlled by the conventional drugs? Is one is trimetazidine, which is working at inhibition of beta oxidation of this free fatty acid, is most important one. Then late sodium current inhibitors are ranolazine. It also has CPT1 effect inhibitions little. Then most important entry of free fatty acid into the mitochondrium is CPT1 and 2 inhibitor. It is perhexylene. The other drugs which have effect on CPT1 is etomoxir and our old known glucose, potassium, insulin to increase the cellular glucose utilization and decreasing the acidosis. Beta blockers have been found to have some doubtful effect on CPT1 inhibition. We come to one by one drug. The trimetazidine is one drug which is most commonly used, and it inhibits beta oxidation and therefore the decreased fatty acid oxidation. The ESC 2000 recommended this as a second line drug therapy after beta blockers and nitrates. So if you see here, it is free fatty acid, acetyl coenzyme A, intracellular in the mitochondrium. This works here, final pathway, before the ATP is being produced. So it has got beta oxidation inhibition, but it has got also CPT1 inhibition. So both the levels, intracellular and extracellular. To summarize the metabolic effects of trimetazidine, free fatty acid breakdown inhibition and glucose breakdown stimulation. This imbalance is being managed by this drug. There is a reduction in the amount of oxygen necessary for ATP production, because to produce ATP from free fatty acid, you need more oxygen. To produce ATP from oxygen pathway, you need 10 to 15% less oxygen. If your oxygen is producing from free fatty acid pathway, you are going to produce lactic acidosis. So when you block it, there is a decreased lactic acid production, so the acidosis is reduced. So ultimately, it results into reduction in cellular accumulation of sodium calcium. Sodium calcium exchange, the cellular loading of calcium is reduced. This drug has a very short half-life of 6 hours. So minimum, if you are giving for 24 hours, you have to have the twice doses, and the renal excretion is to be taken care. Dose is to be reduced when there is a renal dysfunction. There are no major much side effects so far, but you have to keep a watch on the blood for thrombocytopenia, agranulocytosis, but otherwise nothing much important side effects. This drug has been well tried and has been found successful in improvement of refractory angina in these TRIMPOL 1, 2, and TACT study. And various heart failure studies, even in heart failure studies, this drug has been useful because of improvement in the intracellular milieu, reduction in acidosis, and reduction calcium load. I'll be talking about it later on. Another drug is late sodium current inhibitor, and it has got also CPT1 blocking effect little. This drug is working at stage 2 of action potential. Therefore, the most important side effect comes is increased QT intervals. So all those situations where the position of ischemia causing increased QT interval, commonly ischemic heart disease, or those patients who have already ventricular tachycardia, something like that, because of the increased QT interval, we have to take a special precaution that in situations of long QT, it has to be given with the guided things are to be kept in mind. So both the drugs, trimetazidine and ranolazine, are two drugs which do not affect the heart rate and blood pressure. So very safe to use, and they don't have limitations, but should be used in optimum doses. For ranolazine, QT interval should be kept in mind. So this is ranolazine, not only late sodium current inhibitor, but it also has some effect over the beta oxidation along with, and some endothelial mediated coronary vasodilatation as some pleiotropic effect, not main effect. Therefore, ranolazine plays its important role not only by late sodium current inhibition, but also beta oxidation prevention of the free fatty acids. Various trials have shown its efficacy, that it is in stable coronary artery disease, it's effective to improve the intracellular milieu. Side effects are not very important, except that QT prolongation to be kept in mind, and drug interaction is very important. In all those drugs where you are giving ranolazine, you should keep in mind that all statins and digoxin, if you are giving, reduce their dosage, because they are working through the CPD 450 enzymes. Another important drug of the cascade is CPT1 and CPT2 inhibitors. This is the most important drug for hexylene maleate. It improves the intracellular milieu by reducing the substrate utilization of free fatty acids. This has not been so popular because of its important side effects of hepatotoxicity and peripheral neuropathy. And if it is to be used, then it is to be used for only short time. You are just waiting for a bypass surgery, you are waiting for some bridge situation, 2, 3, 4 months you can give because of these very important side effects. Another important drug is the etomoxib. It's just like nitrate, but it has a potent CPT1 inhibition effect. So its a role in metabolic modulation of the cardiac myocyte milieu is very important, and it is a very important drug that way. But its clinical trial and long-term safety has not been proven so far. Our time tested glucose, insulin, potassium, acting through increasing the glucose utilization by the ischemic myocardial cell and reducing the free fatty acid uptake is one which can be, if you are in a situation and patient is very unstable, this can be used as a part to modulate the intracellular intracellular metabolism. Beta blockers, they have their main effect by reducing the demand, but it has been, one of the study has shown there is a 57% reduction in myocardial free fatty acid uptake, and this was with carvedilol. So not very many studies have proven this effect, but the class effect shows that they have reduction in free fatty acid uptake, and they have been doubtfully found to have CPT1 inhibition. Therefore, just to conclude, metabolic and anti-angiogenic therapies induce a shift from free fatty acid use to oxygen glucose utilization, and thereby increasing the ATP at the cost of lower oxygen consumption. These three drugs, trimetazidine, ranolazine, paraxin have been well documented because of their anti-ischemic effect. These trimetazidine and ranolazine are most frequently used by all physicians, we people, but only we have to understand at what stage these are to be added. Paraxin maleate is the most potent currently available, but because of their hepatic toxicity and peripheral neuropathy, it has not been so popularly used. Trimetazidine and ranolazine, they do not cause phospholiposis. Therefore, they are safe to use. These drugs may also be used in angina secondary to hypertrophic cardiomyopathy, aortic stenosis, all those situations where there is left ventricular hypertrophy causing LV dysfunction. In the last lecture by Dr. Rupa, Dr. Mukesh Gupta asked this question, what is the management of diastolic dysfunction? I think the metabolic modulation of these hypertrophic cells, reducing them by calcium load is one of the important drugs, but these drugs have not been routinely accepted or used in clinical trials versus or in clinical practice because of the cost. This does not give an evident advantage of drug that whether the patient is being benefited by any symptom. Therefore, they are underutilized. Otherwise, on all those conditions where there is a diastolic relaxation problem, these drugs should be used. In addition to the potential use of these drugs in chronic heart failure is also getting recognition. In our own hospital, in our team heart failure trial, which we presented in American Cardiology, the erectile function has improved with the use of these drugs. The myocardial performance index has been useful and improved. So to conclude at the end, the metabolic modifiers are very important drugs which are to be kept at the third line, but if required, they can be used. In one of the study by the Upendra Kaul done in somewhere in 1990, where they have shown the efficacy of ranolazine, trimetazidine, and rubber nitrate 1:1. But we don't use 1:1 as a first line because of the cost. With these words, I conclude. Thank you very much.
Thank you, Dr. Gokru, for the nice and elaborate talk and very clearly explaining the role of metabolic modifiers in angina. So, gentlemen, we are running short of time. So, we are not having question answer session. Now, I hand over the mic to Dr. Sajid to carry on the next session. Thank you. Dr. Sajid.
Thank you, sir, for wonderful presentation. Dr. Rajat is here, our senior, from some quick comment. Dr. Rajat boss from Kanpur. You are muted. Yeah.
This was a wonderful talk given by doctor, but I would like to know from Dr. Gokru the role of this modulator, especially with the trimetazidine, for the prevention of reperfusion injury and their role in the peripheral arterial disease, whether we are using it routinely or we are using it only in the angina cases.
Peripheral vascular disease, it has got no role, nothing to do with it, because there is a fixed obstruction and the vessel cell has not to work at all. We are talking about myocardial cell where the cell intracellular cell metabolism is to improved because it is affected by the calcium load, it is affected by the intracellular acidosis. In peripheral vascular, the media of the peripheral vessel cell, it is not going to cause cell problem. It is the narrowing and reduced oxygen supply to the peripheral tissue. So role of these drugs in the peripheral tissues, whether the skeletal muscle For our other tissues, no study has been done so far.
Thank you, sir.
Dr. Saji, there was one query from my side, if possible, the time
Yes,
permits.
yeah, sure, boss, sir.
Dr. Gupru has presented a very nice and elaborate talk on metabolic modulation. Recently, there is a hypothesis that has come up for SGLT2 inhibitors like empagliflozin that they also do a metabolic modulation, and by changing the ketogenic milieu, they also improve the what you call the ATP production and reduce oxygen consumption. I would just want to know from the learned speaker whether this is also one of the methods of metabolic modulation, and where do the SGLT2 inhibitors stand in this?
This is absolutely true in terms of when we are talking of diabetic management. The exact mechanism of SGLT2 in non-diabetics, which is still not very clear, but pharmacological, if you see their function, they can be of use. But unless they are being done in a long-term trial, we cannot use the SGLT2 as a standard as of right now. But definitely because of their pharmacological property, to these things, there is a future for this.
Manoj, as far as the role of SGLT2 inhibitors is concerned, they have got established role in heart failure. But as far as the coronary artery disease goes, they are not being recommended, at least in coronary artery disease.
Yes, boss, this is a long-standing discussion, and we will discuss again it. Yeah, we like thanks to our speaker, chairperson, and panelist, Virender Singh sir, Gokru sir, Manoj boss, everyone. Thank you, Rajat boss. Please welcome to our next speaker, Dr. Vikas Agrawal. Big name in city of Varanasi. For this chairperson, I would like to invite Dr. Naveen Jamwal and Dr. Gautam Sarup. And panelist for this session is Dr. Jalis Fatma, Dr. Sandeep Chaudhary from Lucknow, Dr. B.K. Singh, Head of Department Medicine, ESI, New Delhi, and Dr. Mukhtar Ahmed from Integral University, Lucknow. Please, Dr. Naveen Jamwal, he is a very renowned cardiologist and special interest in intervention, although he is masterpiece for echo and electrophysiology, but better to leave echocardiography for all of us. He is a masterpiece in intervention. I know he is doing very complex coronary intervention and is life member for all the society and having so many fellowship also. And next speaker, my close junior from my college, Dr. Gautam Sarup. He completed DM from the Lucknow, but he is UG PG from the Jhansi, from same college. And he is a very good intervention cardiologist in Sahara Hospital, doing complex cases very nicely. So over to Dr. Jamwal to introduce my speaker. Dr. Jalis Fatma is here.
Thank you, Dr. Sajid. Yeah, please continue. Please continue.
Yeah. You go ahead. Okay.
You continue. I think you introduce other panelists also.
Yeah, I have 4 panelists. Dr. Jalis Fatma, she is head of department, Era Medical College, Lucknow. Dr. Sandeep Chaudhary, senior physician diabetologist from Lucknow. Dr. B.K. Singh, head of department of medicine, and my senior when I was doing senior residency in the same place from ESI Hospital, New Delhi. And Dr. Mukhtar Ahmed also is also my senior, working on the same place. Right now, he is associate professor in Integral University, Lucknow. Dr. Jamwal, please introduce his speaker here.
Thank you, Dr. Sajid. We are running ahead of time anyways. So I'll quickly introduce our next speaker, Dr. Vikas Agrawal. He's a chief intervention cardiologist at Surya Multi-Specialty Hospital, Varanasi, a big name there. Has many publications, paper presentations to his name. He's an experienced operator and has proficiency at angioplasties. The topic for today is tricky, and we all early diagnosis and management of heart failure. So it's a difficult topic, difficult to manage. Let's see how Dr. Vikas makes it easy for us. Dr. Vikas, please take over.
Thank you, Dr. Naveen.
Dr. Vikas, you can't see you. Your video is off.
No, my video is on.
Sir, video is on actually. Because of the low bandwidth, maybe you won't be able to see.
I'll be off.
Yeah.
Am I visible? My slides with?
Yes, sir. Yes, sir. Your slides are visible.
Okay. It's also moving?
Yes, sir. Yes, sir. It is moving.
Thank you. Good evening.
Just
And
requesting
my
you kindly do the full screen, sir. It is not.
okay, yeah, sure.
Yeah, slide show.
Yeah, thank you. Good evening. My topic today evening is the management of heart failure, early management of heart failure, including clinical inertia and discussion about the ARNI versus enalapril. What is the clinical or therapeutic inertia? Clinical or therapeutic inertia is defined as the lack of treatment initiation or the lack of treatment intensification on par with evidence-based clinical guidelines to achieve the therapeutic goal. Despite robust guideline support for the physician from the last 20 years, including SALT-3 trial, CBIS-2 trial, RAILS trial, IMPACI-HF trial, and recently published ARNI, there is still some gap in the treatment part. First one is a fail to receive evidence-based treatment at all, or do receive treatment but without optimal doses, means optimal target doses as based on the guideline based. This is the CHAMP registry. This is the American registry in which if we talk about the ACE, this is the CHAMP registry about the HFrEF patients. HFrEF patients means heart failure patients with reduced HF. If you talk about the ACE or ARB, only 59.9% or 60% patients on the ACE ARB. And if you talk about the ARNI, only 12.8% patients on the ARNI group. If you're taking combined of the ACE and ARB with ARNI, only 72% on the ACE group, still 26.2% lack the RAS inhibitor benefit. If you talk about the beta blocker, only 66.8% on the beta blocker and 32.9% without any doses of the beta blocker. And if you talk about the MRA, either spironolactone, either eplerenone, there is still only 33% patients on this MRA group and 65% patients is not on the MRA group. And what is the driving factors for this lower GDMT uses? Most important one is the advanced age group, poor functional group of patients, higher NYHA status, lower baseline blood pressure, systolic blood pressures, and advanced renal disease is the main driving component for the lower amount use of this GDMT. If we combine all the drug, more than 30% of the HFrEF patients were not treated despite of no contraindications. If we talk about the contraindication, only absolute contraindications combine all the RAS blockade, beta blockade, and MRA, only less than 2% having their indications for the this contraindications in CHAMP registry. Again, the CHAMP registry, if we are talking about the ACE or ARB, only 60% is not on less than 50% drugs. Likewise, if you talk about the ARNI, less than 56% patients on the less than 50% doses. If we combine the ACE, ARB, and ARNI, 59.5% is on the less than 50% doses. And if you talk about the beta blocker, 45.7% is still not achieved more than 50% doses. Means more than 50% of the subject fail to receive target doses of the GDMT with robust guideline data in last 20 years. If we talk about the treatment initiation, lack of treatment initiation initial at the 3-month was an independent predictor of mortality. If we talk about the beta blocker or with the ACE and ARB, more than 2.5 times risk of mortality in heart failure patients with the lack of treatment initiation at the 3-month. If we talk about the 30-day readmission rate is lower, significantly lower when patients is on appropriate treatment, means on the GDMT based treatment. To summarize therapeutic inertia, there's the two-part perceived pictures and reality pictures. Perceived pictures, perceived stable disease, confounding NYHA2 status. If you talk about the Indian patients, mostly Indian patients, when they have some symptoms, they limit their physical activity, prefer sedentary lifestyles. In that sedentary lifestyle, patient symptoms are very limited. and perceived low risk group. And there is a concerns about always side effects and multiple health care encounters. And there is also concern change therapy if and when conditions worsen. But the real picture is annual mortality is 6 to 20% in the Western population. And in our country, there is up to 30% mortality in 1 year in Trivandrum Heart Failure Registry. This is one kind of good registry. And over 1 million hospitalization each year in Europe and US due to the heart failure hospitalization or due to the worsening of heart failure. And post-discharge mortality is still 25 to 30% within 1 year. In the stable class NYHA2, there is an additional 40% die off due to sudden cardiac death. This is a very important NYHA2 status. There is also increased risk of sudden cardiac death. And this sudden cardiac death can occur without any worsening symptoms. So this NYHA2 status, which is mostly in every trial, is about 70% of population, is a very important. And you also consider this NYHA status to further reduce the clinical event with the help of some newer drugs. Impact of clinical inertia in India. In India, about 75% of HFrEF patients fail to get appropriate medications. In some registry by Dr. Sandeep said, mortality of admitted patient is as high as 30%, and the estimated annual mortality in India due to the heart failure would be 0.1 to 0.16 million. This slides from the Trivandrum Heart Failure Registry is one kind of good registry I have discussed. Is published in 2018. They have shown in mortality of about 3 years. In hospital mortality, there is a 9.7 compared to the Western population, where there so in hospital mortality is about 5 to 6%. There is a cumulative 30-day mortality is about 14.1%. Cumulative 90-day mortality is 19.5%. 1 year mortality is 32%, which is also is very higher compared to the Western populations. 2 year mortality is 42.3%, and 3 year mortality is 46.2%. In this Trivandrum Heart Failure Registry, during hospitalization, only 20% of the populations achieve guideline-directed medical therapy. And during discharge, only 25% patients achieve appropriate therapy in the form of GDMT. Still lacking more than 75% patients not achieving GDMT in Indian scenario. This is the study by the Dr. Hari Krishnan et al. There is only 25% of HFrEF receive GDMT at discharge. If we talk discussing about individual drugs, ACE inhibitors achieve only in 40%, ARB 8.6%, beta blocker in 55%, diuretic in 95% on admissions in the ADHF patients, MRA in 47% patients. Still there is a robust data along with the RAILS and Emphasis HF trials about 35% mortality benefit. We cannot achieve maximum or GDMT based drug doses or initiation of doses for the eplerenone or spironolactone. More than only 25% of HFrEF receive GDMT at discharge. Factors impacting clinical inertia. The clinician factors. The main factor is limited experience in the management of complex heart failure patients. And the statement, my patient is doing fine, why I change my treatment course? At the patient's level, the reluctance to change, cost effect, and poor adherence. And when talk about the system, there's a paucity of specialists, which is a high experience in the complex heart failure patients. If we talk about the physician perspective, they say my patient is stable, then why I'm changing the course of the treatment? I further discuss basically in Indian patients, they have very sedentary lifestyles when they have symptoms, and with NYHA2 symptoms, the activity is very limited, so they cannot complain with their consultants. So in that conditions, clinicians is also very reluctant to not the change of course of the drug. But this clinical inertia is major threat to the patients who may benefit with the newer therapy. As we discussed, this ARNI is having more than 20% additional mortality benefit, not above the placebo, but above the enalapril with the maximum doses. Yes, if we start the drug as early, we can benefit patients more. And this is the very common slides. In HFrEF patients, mortality remains high despite the introduction of therapies over the last 20 years, and more than 50% mortality with the chronic patients after 5-year post-diagnosis. Some paradigm shift is there, and in 2014, ARNI is developed. ARNI is a combination of valsartan with the and sacubitril. And in the recent 1.5 years, the two drugs also is in our tool. This is the dapagliflozin with the DAPA-HF trial, and empagliflozin in the EMPA-reduced trial also add in our tool of heart failure therapy. If we talk about the sacubitril valsartan, this drug is a combination of the valsartan with the sacubitril, and this unique dual mode of action that inhibit neprilysin causes NP potentiation or NP activation additional with AT1 receptor blocker. And this is superior to ACE inhibitors with comparable safety in all stages of the heart failure with reduced ejection fraction patient's journey. The second point is this reduces cardiac stress to protect the heart with results as early as 1 week in the PIONEER-HF trial. In the PIONEER-HF trial, there is a reduction of the NT-proBNP is evident within 1 week, and this pronounced NT-proBNP reduction is achieved in 4 week and 8 week also. But the result is achieved in as early as 1 week. This sacubitril valsartan, this AT1 receptor blocker, causes decreased blood pressures, decreased sympathetic tone, decreased aldosterone level, causing decreased fibrosis and decreased hypertrophy. And this neprilysin inhibitors inhibit the neprilysin. So NP potentiation is there, leads to further decreased blood pressures, decreased sympathetic tone. Here is further additional benefit of increased natriuresis and decreased vasopressin and decreased aldosterone, which further causes decreased fibrosis and decreased hypertrophy. This sacubitril valsartan in PROVE-HF trial also show some remodeling benefit in the terms of EF, improvement in EF, improvement in some end-diastolic volume index and systolic volume index, left atrial volume index, and E/E ratio. This sacubitril valsartan acts on underlying structural and molecular abnormalities which drive disease progression that is silent and life-threatening. If you talk about the result of the PARADIGM-HF trial, which is the on chronic HFrEF patients with a stable more than 4 weeks of a stable course of treatment, there is a 20% reduction of the mortality benefit composite of death from CV causes or first hospitalization for heart failure. This is above the enalapril, not above the placebo. So there is an additional 20% mortality benefit. If we talk about the death from CV causes, there is an additional 20% reduction compared to the enalapril. If we talk about the first hospitalization for heart failure, there is a 21% reduction in the first hospitalization for the heart failure event. If you talk about the death from any cause, 16% death reduction from the any cause compared to the enalapril. This is a very important slide. If you talk about the all-cause death or CV cause death, there is a significant reduction in the ARNI group. And this driving factor for the CV cause death is derived also from the sudden cardiac death. And this sudden cardiac death is also 20% reduction in ARNI group versus the enalapril group. And this sudden cardiac death is also common in any stage of the NYHA, either stable stage of the NYHA group patients. If we talk about the worsening heart failure, still 21% reduction of worsening heart failure. The majority of death in the PARADIGM have a CV causes. The mortality benefit of sacubitril valsartan is related to the observed reduction in the sudden cardiac death and death due to worsening heart failure. Sacubitril valsartan also improves physical and social activities, as in the form of dressing, showering, climbing a pair of stairs, walking 100 yards, visiting family members, jogging, doing yard works, hobbies, doing household chores, and sexual relationship. And also in the terms of KCCQ scores, beneficial in the terms of KCCQ scores, which measured at the 4-month, 8-month, and 12-month intervals. Significant increase in odds of achieving a 5-point or greater improvement in change scores at 4, 8, and 12 months. This sacubitril valsartan, this prolonged life by 2 years as compared to the enalapril. If we take average age of 55-year populations, their mean year survival is increased more than 2.1 year. And if we take about the 65-year populations, here difference is 1.6 year. If you're taking averaging, the sacubitril valsartan increases life by about 2 years. This sacubitril valsartan reduces the rate of 30-day all-cause and HF readmissions, because the main driving force for this HFrEF patients is the readmission, and this readmission create extra mortality. In the case of sacubitril valsartan combination, there is a 38% lower rate of readmissions compared to the enalapril, and 26% lower rate of 30-day readmission for any cause. Likewise, there is also 23% reduction in the cumulative number of hospitalization for heart failure patients per 100 patients. This is also very good slides. Sacubitril valsartan impact on worsening and clinical instability. Intensification of outpatient therapy required 16% reduction requirement in the case of ARNI group in the terms of diuretic doses. If we talk about the ED visits, emergency department visit is also significantly reduced in the ARNI group. When I have discussed this 21% reduction in the hospitalization for heart failure. If we talk about the IV inotropic drugs treatment in the recent or admission for the heart failure, there is a 30% reduction at the use of IV inotropic drug. And lastly, there's a more advanced treatment for the heart failure, either CRT, ventricular assist device, or cardiac transplantation, which is also significantly lower in the ARNI group compared to the enalapril group, which is 22% reduction in the ARNI group. If we talk about the guideline recommendations, in 2016, ESC and ACC, they recommend class 1 recommendations, and ESC, they commend sacubitril valsartan is recommended as a replacement for an ACE inhibitor to further reduce the risk of heart failure hospitalization and death in ambulatory patients with HFrEF patients who remain symptomatic despite optimal treatment with ACE inhibitors, beta blocker, and MRA. This is a class 1 recommendation. This class 1 recommendations for the NA patient and class 1 recommendations for that group of patients which on ACE and ARB to further reduce of the event. If you talk about the Indian patients versus overall study, there's at par results compared to the All Asia, East Asia, and South Asia patients in the terms of primary composite outcome, which is the component of the CV death and heart failure hospitalization. Likewise, CV death is also at par. If you talk about the heart failure hospitalization, Indian patients results same. Summary: ongoing clinical inertia is a big challenge in HFrEF patients management, which includes failure to receive evidence-based treatment at all and to receive treatment but not at optimal doses. In India, 75% of HFrEF patients fail to get appropriate medication. Hence, the mortality of admitted patient is as high as 30%, and estimated annual mortality in India due to the heart failure would be 0.1 to 0.1 million. This sacubitril valsartan is the first in class ARNI with the unique actions, 20% additional benefit of mortality compared to the ACE inhibitors, and this help patients stay out of hospital, live longer, and feel better in terms of quality of life. There is an additional 20% risk of sudden cardiac death, still in lower NYHA status or all group of NYHA status. Thank you.
Thank you, Dr. Vikas, for nice
Dr. Vikas,
elaboration.
that was a very nice.
Yes, Dr. Jamal, go. Yeah.
Very nice and very crisp presentation. Dr. Sajid, do you want to have question answer session, or because we are running late? So
No. If any question, yeah, you people can go ahead.
You asked something about ADHF.
Dr. Gautam, do you want to ask?
Acute decompensated heart failure.
So if I conclude this Dr. Vikas presentation, it was a very nice and crisp talk. And the take-home message will be the thing that every molecule that is introduced by a trial and that is scientifically tested, that is tested on the maximum tolerated dose. So it is our goal that as early as possible we should diagnose the heart failure early, because it is going to alter the clinical course and the natural history of the disease. And over the period of the time, this is the important thing which we'll all have to be take care in our mind, that how to get your patient at the maximum tolerated dose. Mainly this is the inertia, and it is both on the patient part as well as the treating physician part. We should always take care of mind that we have to increase the beta blocker dose, increase the ACE inhibitor or ARNI dose to the maximum tolerable limit, so that we can pass the maximum benefit and the maximum mortality reduction at the maximum tolerated dose. This is the main inertia. This is both at the patient as well as doctor's part, and it is our wisdom that we have to pass on the benefit, and we have to sensitize our fellow colleagues as well, that each and every patient should diagnose early in the course, and the treatment part will achieve the maximum tolerated dose. Thank you.
Dr. Vikas, I have got one query. In the light of 20% mortality benefit, will you replace all the ACE inhibitors in all the cases of CHF with sacubitril valsartan?
Yes, sir.
And what is your experience with acute pulmonary edema, those patients having acute coronary syndrome in ICU? Would you start sacubitril valsartan in those patients?
Basically, sir, this paradigm HF trial is on the outpatient patients. On the two trial, and this pioneer study and this transition study, they show benefit in the form of anti-proBNP, but still there is a concern that you have to use these drugs after stabilization, after stopping the IV diuretics drugs. So still in the case of acute pulmonary edema, acute CHF, you have to not use these drugs. You have to further decongest the patients and put on oral diuretics, and patients should not be on the IV inotropic drug, because there is a major concern is always with the symptomatic hypertension is much more common with this ARNI group compound. So you have to avoid these drugs during acute pulmonary edema stresses, but you can start this drug in ADHF patients after initial stabilization, with positive in the terms of anti-proBNP level and positive in the terms of readmission level of 1 month to 2 months.
Thank you, Dr. Vikas. Our chairperson and panelists, can we go for next session, please? Samir.
Thank you.
Okay, welcome to next speaker and next session. A very renowned speaker in field of clinical and non-invasive cardiology, Dr. Prashant Advani. Maybe I met him personally somewhere, if I remember it. And chairperson for this session is Dr. Pankaj Agrawal and Dr. Kausar Usman. And panelist is Dr. R.R. Singh from Jhansi, Dr. Nanak Saran from Ayodhya Faizabad, Dr. Rakesh Srivastava from Lucknow, and Dr. Arun Pandey from Lucknow. Dr. Nanak Saran, Dr. R.R. Singh already I introduced, I call him again. Dr. Nanak Saran is a leading physician and diabetologist from the Faizabad. Rakesh Srivastava, our very close senior from Jhansi, MD and consultant physician, and is very active in Diabetic Association. Arun Pandey is a well-renowned diabetologist, he is DM endocrinology and doing very well. And he is mentor in our LDHS society. So I would like to introduce our speaker also, Dr. Prashant Advani, because I think till now no chairperson has joined. He is Dr. Prashant is the MD, and after that he has so many achievements. He is a consultant, 21 clinical cardiologist. Yeah, am I audible?
Yeah, you are audible. Yeah. Dr. Sajid, I am.
Yeah. Director Advani Heart and Metabolic Care Center, Raipur, and honorary visiting consultant at various corporate hospitals. No need to read detail, Dr. Prashant, you go. I know you are a very firebrand and very good orator. Yes, go ahead. Start with.
Yeah, thanks, Dr. Sajid. How to start sharing? 1 minute. Let me know. I'm in. Oh, my slides are visible?
Yeah, yeah.
It's from beginning. Yeah. Good evening, all, and we are already at the fag end, and this was a wonderful conference. And I once again thank Dr. Sajid Ansari, BI. Good evening to chairperson, elite chairperson, and panelist. And I think we are bored. It is the fifth or sixth in the row, and one more to go, and I'm penultimate lecture. And this is such a vast topic delegated to me. We can have a 2 days conference for this thing. But what I do, I would just like to summarize everything, entire pathophysiological thing, Indian characteristic of diabetes or anti-diabetic drugs, and what are we facing in a young Indian population. I'll just wrap up the new paradigms, new perspective, new diabetes. Literally, it is going to cover entire cardiodiabetology, 10 to 15 minutes or at max 18 minutes I would like to take. But we encounter day in, day out patient, OPD in the garden variety patient, 35, 34, 36, a walk-in patient. And then he comes with a lab report, HbA1c 6.3, triglyceride 220, total cholesterol 180. And this is we and you have seen so many times. This all is coming from a syndrome called metabolic syndrome. It is originating from visceral fat, perinephric, perihepatic fat. So we deposit so much of visceral fat, ominous fat. So we have a different anthropometric and demographic characteristic in India. Type 2 diabetes that we are alluding to here, which is 95% of the total diabetic patients, is just is coming from central adiposity. It's a fat and weight which are driving the syndrome. So why I'm saying all this? Because by the time you diagnose diabetes and you have a constellation of other cardiovascular risk factor, you may have a sudden cardiac event as the first thing, or sudden cardiac that we see youngsters. We have so much of premature life loss. So these drugs that are being researched upon ever since the mandate of US FDA in 2007, that any new anti-hyperglycemic agent industry is making has to prove its cardiovascular safety, thanks to the failed meta-analysis by Steve Nissen of rosiglitazone. But that's not the story here. The kind of pathophysiology that we have in type 2 diabetes, more of insulin resistant, relative insulin deficiency, ominous octet is full of insulin resistant offshoot like high hepatic glucose output, peripheral hyperinsulinemia, decreased blunted incretin effect, and heightened glucose absorption of proximal tubules. So we have novel molecules coming. We know that in diabetes, if you are managing, you have to prevent the ASCVD events. We know that ASCVD is all diabetes. Diabetes is a vascular disease and heart failure equivalent. 80% or more people have ASCVD, more 75% coronary artery disease, few are ischemic heart disease or carotid or peripheral, and 75% hospitalization are because of ASCVD. So it's no longer a cosmetic glucose correction. It's overall, it's a vascular disease, deadly. It's a CAD, CVD, and heart failure equivalent. There's no, and then as I was alluding in my prologue speech, that's coming from visceral adiposity and contributing to entire homeostasis of body in a very negative way, discharging so much of angiotensin 2, free fatty acid, inflammatory markers, CRP, decreasing adiponectin, increasing. So it's a seesaw balance of vascular endothelium, which is purportedly the biggest endocrine organ of the body, towards it being more pro-constrictive, proliferative, pro-inflammatory, pro-oxidative, and pro-thrombogenic. So this all can it's coming from a complex. We are genetically predisposed, and by virtue of lifestyle, the way we are exposed to the environmental interaction, so genotype phenotype interaction in India, and this is the manifestation. So why this all is necessary? Because the drugs that we are going to discuss, and they have good outcome trial and they have good robust data. How do they address this pathophysiological loss? Well, we know that multiple assault on the vascular system through type 2 diabetes, hyperlipidemia. It's kind of an atherogenic hyperlipidemia. You have a not that high, robustly high LDL. You have qualitatively abnormal LDL with a borderline, have a small, dense, and high ApoB. Then you have high TGs. You have low HDL. So it's atherogenic, which may not be matching with the Caucasian counterparts. And all the studies we base on a hypothesis on are being represented by Caucasian white race people. You have pro-thrombotic state coming from pro-coagulant and antifibrinolytic effect. You have insulin resistant, hypertension, vasomotion abnormality, so much of inflammation, oxidation. So that's clogging it. So your heart is assaulted from everywhere. And you have diabetes heart, and can you know that it's a monster of diabetes. It's a vascular disease, all pervasive everywhere. It affects everything. Pump, pipe, and filter. This we have to remember. The pump is the cardiac musculature. Then your pipes are the coronary arteries, and the filter is the kidneys. And this is going everywhere. So the moment you have started developing even iota metabolic syndrome or type 2 diabetes, even the HbA1c 6.5, you may have other diabolic accomplices pushing hard on your endothelium, causing so much of shear stress, a subluminal, subintimal, very nascent atherosclerotic plaque, which might just rupture and give you an ACS or a sudden cardiac death, even before you are frankly diabetic. So we have always a debate ever since I was in medical school. I did MBBS, MD in my DNB training. You never I was told that the sugar control gives you all benefit, but then the paradigms have changed. We know that microvascular complex, there is some linear relationship. microvascular, neuropathy, retinopathy, nephropathy. But then for macrovascular complication, 80 to 85% morbidity mortality coming from macrovascular complication. There's no real relationship with glycemia. And we base all these decisions on these landmark flagship trials. Though as a cardiologist, I would reckon these trials, UKPDS, ACCORD, ADVANCE, VADT, in all those trials in many years into the diabetes and with multiple already the organ afflictions, the patient will enroll at age. The UKPDS was a kind of primary prevention. All were high-risk diabetic patients. And in those trials, intensive glycemic arm were fared very worse. So we know that glycemic control is the way, if you want to prevent cardiovascular heart outcomes, only glycemic control, glucose-centric approach is detrimental. Because macrovascular complication involves so much on the background of inheritance of polygenic penetrance, your individual inheritance, then your lifestyle, glucose, smoking, blood pressure, obesity, so it's mixed up. We know that ABCD of diabetes is huge. And microvascular complication, your background genetics, glucose and blood pressure. So it's a linear kind of relation. You can predict microvascular, but not macrovascular complication. And glycemia and cardiovascular disease, uncontrolled diabetes may have for a longer. We know that there's a concept of glycemic legacy. You diagnose somebody new, then go all guns blazing and offer him a metabolic memory, glycemic memory, lipid memory, vasomotion memory, and impact of diabetic medication. Now there's an era of proper medication use. We know that in hypertension, you have guideline-directed medication as per the target organ limit. You have a double drug to be started within a sub-maximal dose, and then so we have some protocols set. In diabetes also, now we have triaging and algorithms coming from various society. I'm going to allude to in the later part of my talk. So diabetic medication improperly chosen may have impact of patient getting heart failure or multiple comorbidities, repeated hyperglycemia. So you have to choose the right drug. A strict control and less robust control on macrovascular complication. And if somebody is frail, senile, multiple events, and if you go HbA1c 6.57 just by unknowingly or by ignorance, you are not offering. So first tenet and commandment on medicine, offer no do no harm, even if you don't offer any good. So my message here is glycemia is not the diabetes management. So glucose centricity is out now. And diabetes affects heart through coronary involvement, microvascular involvement, cardiac, parenchymal, by causing architecture disarray. Beautiful talk by Gokru sir that how metabolic abnormalities, subcellular, intravascular calcium overload, calcium signaling, that all happens at I showed you a slide, how heart is impacted by this, and you have EGs, polyols, inositol, AMP down. So there's multiple things that are happening, and the background of inflammation, oxidation that it causes, and it gives you kind of a diabetic cardiomyopathy coming from ischemic heart disease through epicardial artery, or without epicardial, so much of microvascular incompetence, and you have pure ischemic cardiomyopathy coming. And you have so many glucose lowering drugs, injectable, oral, combined together. We are hitting hard on the new buzzword is to hit hard on the ominous octet on the syndrome of type 2 diabetes. But then what do I choose? It's an era of precision medicine. Which drug for which population? And I know that in India, even in younger people, in late 20s, early 30s, and early 40s, I have to prevent hard outcomes, cardiac death, non-fatal MI, stroke, and hospitalizations. So there are new approaches, and out of these so many drugs, you have newer drugs like GLP-1. We have been discussing for 10 years now, and we have outcome data from last. So after 2010, ever since the US mandate, FDA mandate, which of course they have relaxed, that you have to prove CV safety, and then Zinman's trial, the EMPA-REG, that you have a boom moment that you are discovered first time in the century that you have an anti-hyperglycemic drug causing cardiovascular life prolongation. So these mechanisms are kind of novel. They stimulate insulin secretion, endogenous insulin release, inhibit glucose release. They prevent, even in India, we have so much high carb, so preventing intestinal glucose absorption, and consequently less postprandial hyperglycemia, hypertriglyceridemia, inflammation, oxidation. You are in time in rage, less of so endothelial eased out. The syndrome of vascular inflammation, subtle vascular inflammation, vessel is on, endothelium is on fire, is eased out by these novel mechanism drug and by SGLT2 inhibitor, which and DPP4 inhibitor. DPP4 inhibitor mimic more closely to ideally, if I was exercising more, if I didn't have any visceral adiposity, I would have behaved in such a way. A DPP4 inhibitor pill might give me that advantage just through a pill solution kind of thing. So GLP-1 agonist, you are directly mimicking in incretins, or DPP4, you are endogenously, by inhibiting its metabolism, you are promoting GLP-1, and SGLT2 inhibitor, you're preventing the absorption of the glucose that is filtered, which is heightened hypertrophy of SGLT2 receptor in proximity when diabetes is part of the amino octet. And by AGI, alpha glucosidase, it's kind of a TDS. You eat something, it doesn't get absorbed by disaccharidase inhibition. So your all glucose load gets down because of we have a simple fiber, high saturated fat diet in India. And then CV safety parameters are not, I'll just rush through it. Cardiovascular death, non-fatal MI, these are standard, pretty standard points for 3-point MACE for all cardiovascular trial. Sometimes 4-point hospitalization for anginas and revascularization. Then when nobody talks about heart, then when they're devised all this, no mention of, there's a kind of an elephant in the room. We say elephant in the room, no mention of heart failure. Then they realize that heart failure, all these trials, ever since the mandate, we witnessed all these trials, all gliptin trials, SGLT trial, GLP-1 trial, and these are some of the landmark flagship SGLT2 trial, EMPA-REG, CANVAS, and DECLARE-THEME. And we know that 3-point MACE-wise, EMPA-REG and CANVAS. Empagliflozin, canagliflozin takes the precedence, and DECLARE-THEME, you cannot cross-compare the trial because for the simple reason, the type of the population that you include in these trials, maybe secondary prevention, high, and the moment you have an ACS or any cardiac affliction, you are at the extreme risk, high to extreme risk. So I'll come back to how to risk assess even the young patient who visits OPD. And they are GLP-1 receptor agonists. So there are heterogeneous results. So we can have a class effect for something, and we can have a heterogeneity for something in the same congener elk. So I'll come back to this concept. So large CV, I'll nutshell, if I put it here, all gliptin trials were, except that sexagliptin, which is also we don't use much in India, all flagship gliptins like Lina or Sita are CV safe and CV neutral. Of course, they didn't exhibit any benefit, but then GLP-1 receptor agonists, they were found to be anti-atherosclerotic because of their pleiotropic effect. We'll discuss. And liraglutide, semaglutide, and albiglutide, dulaglutide in various trials showed a 3-point MACE positivity. And most of the SGLT2 were kind of positive, but then they reduce atherothrombotic events, and this is a discussion. It's still raging. We know that as we were discussing in the metabolic section, Dr. Gokru's talk, that what is the final mechanism, and of course there are pluripotent mechanism for SGLT2. The moment you take a pill and you cause glucosuria, smart glucosuria, aquaurisis, natriuresis, calorie loss, and then there are cascading events that happen in the body will manifest into, I'll come into that. So what is that final mechanism? So there are of course tangible benefits, but then there are more heat than light. So what is that final, if I were to say? So if I take a pill, I don't let that glucose get absorbed, and that too from the heightened receptor density. So you block it, you all lose your calories going down, your eventually HbA1c. So of course, an anti-diabetic pill, so HbA1c goes down, and the magnitude of HbA1c fall would be dependent upon the presentation HbA1c, and then inflammation consequentially, the arterial wall are more compliant, the resistance is eased out, your afterload is down, your preload because of the volumes down, aqueous order, and then there's no consequential neurohormonal activation. You take any blood pressure bill, there's a consequence, it nullifies everything. It doesn't happen there. And there's a tubuloglomeralular feedback. So the pluripotent, so you lose your weight a bit, you decrease your systolic blood pressure, diastolic blood pressure, you eased out your preload after, and you shift your metabolism from free fatty acid to ketone body at Dr. was saying. So you economize on oxygen molecule for ATP generation. So one pill and so many effects. So it becomes a cardiac pill, it becomes a nephro pill, it becomes a kind of a single pill, polypill, many effects. So we have visceral fat loss, and patient doesn't do himself, a pill is doing for him. This is when we know that we have been listening in these pandemic times on virtual CME, so many such talks on SGLT2, and these are not. Finally, you decrease HbA1c, where it's called Stannard 2 effect. We know that there's a landmark trial in the Stannard 160 odd patient were followed for risk factor reduction. And if you reduce your risk factors, you don't gain weight, you lose weight. If you take sulfonylurea, you may control glycemia, but you increase the weight, you take insulin, you increase the weight, and you nullify everything. It rather poses extra burden for your cardiovascular propensity. And also you decrease your microL, and eGFR is sustained. And again, I come back to the landmark. It started with 2015 for EMPA-REG, then Canap followed the suit, then DEPA, and then this year virtual ACC ertugliflozin trial, and includes diverse population. EMPA-REG population, we have to understand all for secondary prevention, have prior documented coronary artery disease, revascularization, anginas, old ACS, or PEDs, or all secondary prevention, all green. Canvas program 66%, and then declare 40% for secondary, but more of a primary prevention. That's why they didn't get a kind of cardiovascular death Kaplan-Meier. So ultimately, FDA approved empagliflozin for the first time in the history in late 2016 as a cardiovascular death reduction in diabetic patients. And also, there are so many added advantages. But you see in this bar point of estimate hazard ratio diagram, so there's a high heart failure even with verticillin ertugliflozin, it was positive. So heart failure is emerging. There's an innuendo as a kind of a class effect, and also kidney parenchymal preservation is kind of a class effect. But there's a heterogeneity for MACE and cardiovascular death. So 3-point MACE or composite. And then if you give, then there are so many animal in vitro studies, it reduces atrial remodeling. We know that the HFpEF, there was talk by madam for HFpEF. So even if you are otherwise stable, you are kind of class 1 or 2 in terms of shortness or fatigue, but then you are still having subtle structural subclinical abnormalities smoldering, and empagliflozin corrects that too. So that generates a thought that it is an anti-hypertrophic, anti-apoptotic, anti-fibrotic effect on a long run. By virtue by calorie loss, it actually eases out your vessel and stress and afterload on your cardiac myocyte, and cardiac parenchymal micro and macro architectural disarray is prevented. And this remodeling benefits are were shown in EMPA Heart. That in EMPA Heart study, there's a regression, as with Dr. Agarwal's talk, that there's a negative remodeling. So reverse remodeling, improvement in cardiac indices, eccentric index go down, ejection fraction improves, LA strain goes down, LA size goes down, LA volume index goes down. So many, you are taking a pill for diabetes and you have so many pleiotropic, cardiovascular, cardiorenal, and cardiovascular. So and then heart failure. It's an unrecognized complication, and suddenly somebody is getting admitted for PND and orthopnea, means he must have had so much of cardiovascular insult preceding that event, which we didn't recognize, we didn't pick up. So there's a rationale for using SGLT2 inhibitor in heart failure trials. So for last 4 years, when the signals were coming from EMPA-REG declare, they said, why not have a dedicated heart failure, even in non-diabetics? Because the pathophysiology in heart failure is same, diabetes, no diabetes. Then you glucosuria, natriuresis, and smart equiuresis happen even in non-diabetic patients. And EMPA-REG patient had independent of glucose. So EMPA-REG, all effect of heart failure, independent of glucose. So then you have in both in heart failure and in diabetes, inflammation, oxidation, reduced natriuresis, so much of sympathetic nervous system, RAS expanded, interstitial volume disturbed. And when we know that SGLT2 inhibitor, even better than kind of a smart diuresis, they don't contract your intravascular, they don't give you postural symptoms, they don't lead to neurohormonal activation rebound. So why not a taste of the pudding lights in testing to put it on a trial? And also there is sodium hydrogen exchange. We talk big and we have drug for it. And SGLT2 also inhibits sodium hydrogen exchange because it's a part of diabetic syndrome. So the EMPEROR program was decided after DEPA-HF that happened last year. And we still know that heart failure will preserve ejection fraction, as Dr. Vikas said, with just no holy grail tab, there's no therapy yet. And could it, like it can strike there too? So their EMPEROR program for reduce the trials were virtually out. It's again a millennial trial. This year's virtually AC. I was listening to Paul Alter. He was presenting this trial. And likewise, you also know that I told you the diabetes is a monster. Liver, heart, and kidney are going all together. And there's a cardiorenal axis in diabetes. You have cardiorenal syndrome type 1, 3, 4. Acute or chronic dysfunction of one organ causes acute or chronic dysfunction of other organ. And type 5 is a systemic disorder affecting both together. It's diabetes. So diabetes is a type 5 cardiorenal disease. And then you have interaction. So you have affliction of one and causing affliction of other organ, and then you need something which is a missing link in heart failure. So missing link in heart failure is a kidney issues. You don't tackle kidney and heart failure. You are as eGFR decreases, your chances and your heart outcomes goes phenomenally high. So this is a known medical school teaching. So SGLT2 winner can take the bomb. And so this was the same. When we know they reduce cardiac preload, shift to ketone metabolism, cellular programming and subcellular signaling and transcriptional benefit happen, sodium hydrogen go down, renal parenchyma is preserved, endothelial function. So why not trial and a trial? So Emperor reduce in DEPA-HF, and they become the buzzword, and there's a new paradigm, new thinking that diabetes, we know that causes coronary, kills you through CAD, ASCVD, and heart failure. But now we have a pill that actually addresses. So typical patient 18 and above, class 2 or 3 symptom, or also 4 ambulatory sicker patient, higher NT-proBNP as compared to DEPA-HF, they were more sicker. And all on guideline-directed pedals. We know that there's a triple therapy, ACE inhibitor, ARB, ARNIs, as he was discussing, cardioselective, heart failure, beta blockers, MRAs, everything there, and also CRT devices and ARNI. And the primary endpoint, the pretty standard for heart failure trial, composite of cardiovascular death, heart failure hospitalization, emergency visit for heart failure. You may not get hospitalized the patient. You just adjust the medication, inject Ditor, and then send him back. That would be counted. So first secondary endpoint. And as I told you, cardio-renal goes hand in hand. Cardio-renal goes hand in hand. So all these heart failure trials now are taking kidney as a secondary endpoint. And to everybody's expected surprise, it came all positive. 25% reduction of primary composite means cardiovascular death and heart failure hospitalization. And for heart failure hospitalization, first and recurrent for the same patient, 30% down, and 50% renal endpoints, major adverse renal events, doubling of serum creatinine, progression to macroalbuminuria, requirement of renal replacement, dialysis, and enduring preservation. So amelioration of glomerular sclerosis as anticipated. And this happened wonderfully and replicated by DEPA-HF, even in more sicker patient by Emperor reduced. So empagliflozin is a hero here. So heart failure and diabetes and trial. And so how do this happen? How does this happen? So you take SGLT2, you causes glucose reaching to distal convoluted juxtaglomerular apparatus causing afferent arterial constriction. Afferent arterial constriction. Hello?
Dr. Prashant, please, can you conclude the session? Yeah, please. We are going late.
Okay, right. I knew that. Okay, so there are so many dedicated DKD sound. So I was about to elaborate what's happening in the future, and after a very long time, you have glomerular hypertrophy drug, and so many trials had come and all bombed. SGLT2 after ACE/ARB after long hiatus, and these were the trials going on. And then you have for secondary prevention, primary prevention. As I told you, the report card would be MACE superiority. Of course, you have some high risk for CV event. Then you have to risk stratify. I would have showed you a 2 case-based study, how in India we do that. So what is the management? So then instead, as requested by Dr. Ansari, I instead had to, without dealing with this. So then Gliptin said, you have trial this. So ultimately, the guidance has come from ESC that even without metformin, if you have a very high-risk CV patient, you have to first see, risk stratify heart failure. You have to see for CKD, you have to see for ASCVD and risk. And then you have to observe metformin, and even without metformin, one can have a same has been replicated in ADA 2021 this year. So this is going to be even a future. This is the program. This is going to come in that way. So SGLT2 inhibitors are more than just like a statin for the heart. Like we have more than this effect. And for heart failure, they are kind of similar after SNRB. And these are the drugs and tenets for A, B, C, D for diabetes management. Your statin, and then you have to lower HbA1c by specific method for that individual, and sulfonylurea secretagogues are down the line. So taking points, fundamental paradigm for vascular disease, and this is orientation shifting from glucose centricity to this. You have to choose the right drug for right situation. And I was about to tell you a case, but then of course the positive time, and it's a drawback of having the lower side of the spectrum of talks. And emerging data should focus on type 2 from comprehensive risk reduction, and cardiologists and physicians to take precedence in diabetes management. Thank you. Thanks, Dr. Sajid. Thanks, everybody.
Thank you, Dr. Prashant. I think our panelist has already joined Dr. Rakesh Srivastava and Dr. Arun Pandey. Dr. Rakesh Srivastava here.
Yeah, I am here.
Yeah,
am I audible?
Some quick comment.
But that's one question. Well, first of all, I must congratulate you for managing this conference such a successfully on your own shoulder. and I congratulate Dr. Advani for a good deliberate talk. And two questions small. Regarding cardiac point of view, EMPA or DAPA, which is better? First question. And can we combine in a CHA patient with diabetes, SGLT2 inhibitor plus ERNI and valsartan together?
ERNI and valsartan together. ERNI is valsartan, right? ERNI is part of valsartan. Yeah, so
that and this EMPA DAPA together.
EMPA is in DAPA. You have to select your molecule depending upon what is the percent. It's a DAPA has the data for heart failure. EMPA has the data, and EMPA, if you have prior cardiac event, like most of our young patients have a PCI done, you have coronary artery disease documented, high stress echo, high CT and CAC score, CT angio positive. These patients they have not developed heart failure yet, but they are type A heart failure. They have potential to develop heart failure. So these guys should receive empagliflozin, or mostly in combination with, because you require more than 2 drugs for that. So linagliptin, I was about to tell you how the case befits. You take gliptin, you embed DPP4, which is there in the fungi also, and if you inhibit that, then lesser propensity of SGLT2 causing mycotic genital.
So, I'm just asking, which is better, DAPA or EMPA?
For EMPA for MACE reduction, and DAPA for kind of a multiple risk factors, and yet not have ASCVD. And if you have documented HFrEF, chronic heart failure with reduced ejection fraction, you have a choice, EMPA, and somebody is having repeated hospitalization, more than 2 in a month, then EMPA is better than, because the EMPA reduced, then DAPA HF took very serious patient even on ERNI. And your second question, valsartan and ERNI, valsartan is part of ERNI, right? Sacubitril valsartan. So you shouldn't be using, makes no sense. And of course, you cannot use ACE inhibitors ever with ERNI.
Thank you, Dr. Prashant. Dr. Arun is here, please. Dr. Arun. Dr. Arun Pandey, some closing remarks from you.
Wonderful talk by Dr. Advani. He has taken to the journey of the diabetes management, right from the glucocentric to now having a risk stratification and choosing the patient around. Wonderful talk. Thank you.
Thank you to Dr. Advani, Dr. Rakesh Srivastava, Dr. Pandey, and everyone for joining. Yeah, coming to last session of today evening, and speaker is very close to me and my heart, Dr. Deep Pant. He started their journey from MBBS from Darbhanga, MD from Jhansi. He was close junior to me, and DM Cardiology from PGI Chandigarh. Chairperson for this session is Dr. Rajiv Awasthi, well-renowned physician diabetologist from Lucknow, president of API, LDSS Association, and he is very academic and so many membership and various research paper. Just one paper published that is from our society in ESD also. Dr. Vineet Shah, the second chairperson, he is a very good, he is joining from Ahmedabad. He is working as a clinical cardiologist in Apollo Group of Hospital and managing cardiac lab and doing very well echocardiography in Ahmedabad. He is quite famous doctor. Panelist for this session is Dr. KP Chandra, my friends, well-known diabetologist from Lucknow. Dr. Vivek Agrawal, physician and diabetologist from Lucknow. Dr. Nitin Ranjan Gupta, well-known endocrinologist, is DNB in endocrinology, and Dr. Santosh Chaubey, he is also endocrinologist, DNB in endocrinology. Please, Dr. Rajiv Awasthi, sir, to introduce our speaker and proceed.
Thank you, Dr. Sajid. I welcome everyone for this last session. It will be taken by none other than Dr. Deep Pant. He is MD, DM Cardiology, is presently working as a professor in Head Department of Medicine, a senior intervention cardiologist, as a director of cath lab at SIMS Bareilly, is independently doing cardiac invasive procedure like coronary angiography, angioplasty, pacemakers in all possible cardiac interventions. He has got experience of doing more than 12,000 cath lab procedures, including 3,000 coronary angioplasty and 500 pacemakers. He did 25 pacemaker surgery without any cath lab facility at any government hospital in Uttarakhand. Independently done as a primary operator, more than 3,000 angioplasty. Received Uttaranchal Gaurav Award for in 2013 and received fellowship of European Society of Cardiology in January 23. Welcome, Dr. Deep Pant, for your lecture.
Thank you. Thank you. Hello. Hello.
Yes,
good evening, everyone. Good evening, chairpersons. And my dear senior Dr. Sajid, thank you for inviting me. Am I audible?
Yes.
Hello.
Yes, you are audible.
Yes, sir.
So
Yes,
I've
sir,
been
you're
told
audible.
to, yes, sir. Yes, sir. Thank you. I've been told to speak on clinical implementation of new guidelines in management of dyslipidemia. Next. Cardiovascular disease, we know, is the world's biggest killer. Around 17.9 million deaths from cardiovascular disease every yearly. 1 in 10 person aged 30 to 70 years die from cardiovascular disease, and around 31% of all deaths are from cardiovascular diseases. Next slide, please. There is a high premature cardiovascular mortality in India, unfortunately. We see that around 31% premature cardiovascular death in India. Next slide. We all know about the modifiable and non-modifiable risk factors which may contribute to cardiovascular risk, which include diabetes, smoking, obesity, family history, hypertension, high cholesterol, age, and many other factors, which ultimately cumulatively give cardiovascular risk to the person. Next slide, please. Now, evolution of management of high cholesterol has gone a very long journey, starting from HMG-CoA reductase in the late 80s to PCSK9 inhibitors in the recent years. Next slide, please. Now, dictum by which we all physicians and cardiologists work is lower the LDL, lower the cardiovascular risk. Various trials have shown that there is a strong association between lowering of LDL cholesterol and risk factor. Lowering of LDL cholesterol reduces risk factor of major cardiovascular events, as has been shown in this slide. Next slide. They say that if we reduce LDL cholesterol by 39 milligram per dl by statins, it reduces around 21% risk of major vascular events. Next. So we can say lower the LDL, lower is the cardiovascular disease risk, as had been shown in various landmark trials like TNT, Jupiter, and COVID trial. Next. So now let's talk about what do the guidelines suggest. Guidelines continue to recommend lower LDL cholesterol target from initially from 100, now brought down to 70 milligram per dl. Next. Next slide, please. Yeah. So in 2000, we'll be talking about 2018 cholesterol guideline. Patients with very high risk factors like risk enhancing factors like family history of premature atherosclerotic cardiovascular disease, that is age less than 50 years in male and less than 65 years in females, primary hypercholesterolemia, patient with metabolic syndrome, chronic kidney disease, chronic inflammatory conditions, history of premature menopause, and high risk or ethnicities are at very high risk of cardiovascular morbidity and mortality. Next slide, please. Now, continuing about the risk factor, there are risk enhancing factors. More than that, like lipid biomarkers, they say that persistently elevated primary hypertriglyceridemia is also a risk factor. If measured, high density C-reactive protein is also a risk factor for cardiovascular mortality. Elevated little protein A, LPA, is also a relative indication for measurement, especially if there's a family history of premature CAD. Elevated apolipoprotein B levels and apolipoprotein B levels should also be measured in high-risk patients, and a low achial brachial index is also a risk factor. Next slide, please. Now, what about the 2018 Cornerstone guideline? They say that if there is a clinical risk of atherosclerotic vascular disease, then we divide into very high risk and not very high risk. In very high risk, we recommend to maintain LDL cholesterol less than 70 milligram per DL. And we should start with statin, build it to the highest dose. And if not, then we can add ezetimibe. And if ezetimibe is also given and a high dose of statin is also given, later on we can add the new PCSK19 inhibitors. This is done also in patients who are not very high risk. Our goal is to reduce LDL cholesterol to less than 70 or at least to less than 50% of the baseline to reduce the cardiovascular risk. Next slide, please. So talking about the treatment targets and goal for cardiovascular protection, ECC-AHA guidelines. So they recommend that if the LDL cholesterol is less than 90 milligram per DL on maximal statin therapy, we can start ezetimibe. If not, this target is not achieved, then we can add on PCSK9 inhibitors. Next slide, please. The overview of statins is that statins are a group of medicines that can help lower the level of low density lipoprotein LDL cholesterol in the blood. LDL cholesterol is often referred as bad cholesterol, and statins reduce this risk. Why have I been offered statins? Having a high level of LDL cholesterol is potentially dangerous, as it can lead to hardening and narrowing of arteries, which we call atherosclerotic. There are three main types of CVD. That is CAD, coronary artery disease, angina, heart attacks, and stroke. Next slide, please. Many doctors recommend taking statins if we have been diagnosed with any form of cardiovascular disease, your personal history and family medical history suggests that you are likely to develop cardiovascular disease at some point over the next 10 years, and lifestyle measures have not reduced this risk. So we have the different types of statins I've been described in this slide. Next slide, please. So next, please. I'll be skipping these slides. I'll be coming back to next slide, please. So talking about the case study one, here is a 50-year-old diabetic mellitus who with diabetes of 9-year duration on oral hypoglycemic drugs. On investigation, his fasting plasma glucose is 150 milligram per DL, serum cholesterol total is 305 milligram per DL, serum TG is 132 milligram per DL, HDL cholesterol is 30 milligram per DL. Next slide, please. Next. And LDL cholesterol is 249 milligram per DL. What measures would you take in this patient? Next slide, please. Next. So recommendations for cardiovascular disease estimation. First of all, our target, previous slide, please. Please go to the previous slide. Thank you. So for risk stratification is the most important thing in knowing what level of treatment the patient requires. In that, we can do in 3 ways. One is by clinical evaluation. It is recommended that high and very high risk individuals who are identified on the basis of documented CVD, diabetes, moderate to severe renal failure, they should be included in high risk score, and it is recommended that these patients should be at high priority of receiving intensive lipid lowering therapy. Another way is of knowing the 10-year score, 10-year or risk estimation, total risk estimation using an estimation system such as score, such as available in the market, by which we can know our 10-year risk, and based on that we can decide whether we are high risk or moderate risk. Assessment of risk modifiers. In selected individuals at low or to moderate risk, other factors including increased lipoprotein B, lipoprotein little a, C, active protein family history should also be taken into consideration. Next slide, please. Next. intensity loading treatment, using baseline LDL cholesterol and risk of atherosclerotic disease to estimate expected clinical benefit of low density lipoprotein lowering therapies. Next slide, please. Now talking about the treatment targets and goal for CVD protection EAC 2019. They say 30% LDL reduction, more than 50% LDL reduction is recommended as a goal, and especially in high-risk patient, in very high-risk patient, our target goal is to reduce it to less than 55 milligram per DL. In patients who are not very high risk but high risk, in those patients, our target is to reduce it to less than 70 milligram per DL. If the settings are not working, we can add ezetimibe. If ezetimibe is not working, then we can add ACS 19 inhibitors. Next slide, please. Now, strategies to improve patient outcomes and adherence and reduce barriers. Clinical patient shared decision making for initiating therapy. First is assessment of atherosclerotic cardiovascular disease risk assessment. Then telling about the patient about the lifestyle modifications, potential net clinical benefit from pharmacotherapy, cost consideration, and shared decision making. Next slide, please. Recommendations, treatment of dyslipidemia and diabetes. Recommendations, we are talking about ESC recommendations in patients with diabetes at very high risk and LDL-C cholesterol reduction at least 50% from baseline, and LDL-C goal of less than 55 milligram per DL is recommended. In patients with diabetes at high risk, an LDL reduction of at least 50% from baseline, and LDL-C goal of
I think so, sir got disconnected. I'll just check whether he's joining again. Yeah. Sir,
yes, I'm back. So now continuing the risk induction factors. So I think this is the earlier slide, you know. Yes, next, please, next. Thank you. Please stay on this slide only. So studies recommended in patient diabetes who are at very high or very high. Next slide, please. Next. So, continuing the recommendation of hello.
Yes, sir. Yes, sir. Your voice is now audible. Please.
Yes. I'll continue. Just give me half a minute.
Okay, Dr. Pant. Hello. Dr. Pant.
So we're talking about the new recommendation. We were talking about.
Dr.
Yes.
Pant.
Can you hear me?
Yeah. Any problem? Yes. If you have feeling problem in, just make it like panel discussion. You can conclude by your own, and then we will have some discussion with Dr. Rajiv. Yeah. Please don't go for slide. If any problem, you are expert in this field. You conclude by your remarks, by your knowledge. No problem. If any problem in slide.
Okay. I'll try. Just a minute. So I'll conclude. We can say.
I think his internet connection
can
is
say that.
bad. Yeah.
Hello. Am I audible?
Yeah, yeah.
Yeah. So trials of LDL loading therapy indicate relative risk reduction is proportional to absolute reduction in LDL cholesterol. Lowering is better. Lower the cholesterol either with statins or ezetimibe or PCSK9 inhibitors, and it is safe to reduce it to up to 55 milligram per DL. Hence, the intensity of LDL lowering therapy should be based on risks assessment and also baseline LDL cholesterol. So we can say recommendation for pharmacological low density lipoprotein cholesterol lowering, we can say that it is recommended to prescribe high intensity statin up to highest tolerated dose to reach the goal set for specific risk level of risk. If it is not achieved with statin, then we can add ezetimibe. If ezetimibe is also not working, we can add newer drug which are a bit costly, but the cost has been reduced in past I think 2018. We can add PCSK9 inhibitors, which are very effective. They can reduce LDL cholesterol almost to 60%. So by managing mainly the LDL cholesterol, we can manage the atherosclerotic vascular risk factor of the patient.
Thank you. I think we should have some final discussion. We have some eminent doctors here. Is it all right, Dr. Pant?
Yes, definitely.
Yeah. Okay. So, I mean, LDL reduction is the mainstay of treatment. We know LDL is a culprit. Over to Dr. Rajiv Awasthi, sir. What is your idea regarding the LDL? What lower is the better? Everywhere we are listening. What is in your practice? What are you expecting the LDL should be this level?
Yes, as I think there is no doubt about what the guidelines are suggesting. Lower is the better for very high risk patients, especially the diabetic with presence of CAD, strong family history, high LDL-C, and presence of one of the other comorbidities like CKD. So all such patients need very intensive lowering to save lives. But I just have one question from Deep Pant, if he allows me. Like, has the HDL lost its relevance in the quest of lowering LDL-C? Am I audible?
Yes.
So, any comment on the relevance of HDL in presence of quest for LDL-C lowering?
Dr. Pant, are you here?
He's not there. I suppose he has lost his connection.
That
I think, Dr. Sajid, if there are no more questions, then I can ask Dr. Vineet Shah if he.
Yeah, Dr. Vineet is from Ahmedabad.
Sajid.
Yes.
Dr. Sajid.
Yeah, please.
Good evening, all, and nice to see you all.
Yeah.
Very nice conference.
Give
Thanks.
your relevant opinion, something about this current guideline. Yeah.
Actually, dyslipidemia and diabetes is the main major cause for Indian phenotypes. Because of that disease, we are 10 years earlier than other rest of world for a coronary artery disease. LDL is a major predominant risk factors, and low is better. Even one data is there in animal study. If LDL is 20, then with some years, our coronary or arteries will be just like a normal. So lower is better. Presently, with 40-50 LDL, we have a data of around 5 to 10% regression of plaque in some studies. But now, recently, one data for an animal study, if LDL is 20, then complete plaque regression can be happened.
Good, Dr. Vivek.
Yeah.
Over to you, Dr. Vivek Agrawal.
Yeah, I think this was a good topic, and
this discussion will keep on going. The lower is better.
Yes, yes.
But more important thing is that Indians respond relatively better to statins, and we have to look into how much we have to give to lower to a particular level, because 20 mg of rosuvastatin works almost similar to what 40 mg works in the Western countries. And regarding this, there are Indian guidelines also. So we must keep in the mind before we apply the American guidelines to India.
Good.
Hello?
Thank
Dr.
LDL is a target.
we need one question from you. Are you using PCSK9 in
Yeah, we are
CAD
using
patient where LDL is not controlled?
Yeah, we are using PCSK9, and my one patient has after 3 doses of PCSK9, LDL is only 6. Only 6 LDL. So it's a very effective.
And what level you started it?
84.
Then why PCSK9 at 84?
Because patient has 3 episodes of restenosis, even well-controlled diabetes, well habit. He's used to walk 5 to 6 kilometers a day. He's a IS officer, and we prescribe him at the LDL of 84 because main reason we feel it's a LDL. And after starting of PCSK9, he's taking PCSK9 since 2 years. And after PCSK9, there is no any episodes of ACS in his case.
Rajiv boss, any comment? Avasti boss?
Dr. Sajid?
No, I have used PCSK9. I have no experience with PCSK9.
Hello. Dr. Sajid?
Dr. Rakesh Srivastav is here. Welcome. Any comment boss? Yeah.
One question, Dr. Sajid, one question. In a patient of CKD with GFR 30, okay? Okay.
Yes. Yeah.
In a patient of CKD with GFR 30 with CAD, what is the recommended dose of statins? Minimum effective dose with lower GFR 30, 25, 20 with CAD. So statins effective minimum dose recommended.
From a usual age and risk related, we have to give a 50% of dose. If overall this type of clinical scenario in other normal patient without CKD, then 40 milligram, then we have to prescribe 20 milligram in his case. So we are used to give 50% of that criteria in if normal CKD patient, normal renal functions patient.
Okay.
So
now we have to use 50% dose.
Thank you to all. I think this was wonderful discussion, and I think Dr. Deep Pant leave because of connectivity. Thanks to Pant, Dr. Rajesh sir, Vineet, Dr. Vivek Agrawal, another panelist also, Dr. Rakesh boss, and wind up this session and wind up this clinical cardiology and echocardiography update. Thanks a lot to all my participants, those spare their time in the Sunday evening. And there were total, I think, connectivity was around 58, 160 doctor, and this was maintaining throughout. So I think this was a huge gathering, and I am thankful to all. I am thankful to this pharmaceutical company those where make this program success. And I would like to take name of one person, Mr. Samir from Bombay events. He is looking. He was behind me, and he make this program because this electronic part I am zero. Yeah, I know how to speak, but I don't.
One comment from me.
Yeah.
Your topic were of very clinical utility. Day-to-day topic for physician especially. Very good topic of day-to-day practice.
Thank you, boss. Thank you. Thanks to all and everyone.
Thank you.
Whoever listening and not listening. And thanks, Samir, for making this successful. You have done wonderful job.
Thank you, Dr. Sajid.
Thank you. Thank you, boss.
Thank you,
sir.
Thank you.
सबके लिए.
Good night.
Thank you, sir.
Good night.
Good night, sir. Yeah.
Good night.
Good night, sir. Thank you.
Good night. Good night. Samir, yeah, you are on screen. Okay.
Yeah, yes.
Thank you. Wonderful job.
Thank you, sir. Thanks.
ये सबके लिए थैंक यू ऑर्गेनाइजिंग कमेटी के लिए